with the exception of just two people that are new today, I think we were all here. But unfortunately, Rich, DTC, I'm seeing just 3 people here. So the ball is falling on you. We want to recap. Please, from yesterday, what did we hear? Or what did we learn?
We learned that we should take our IPC practices seriously to reduce the risk of infections.
Thank you very much.
We learned that culture and sensitivity test is always important before prescribing antibiotics.
We should set up a surveillance policy where we would ensure that we are taking action to taking data in order to be able to track the trends of infections or microbes that are found.
Thank you all very much. In the fight against this AMR issue, first, if there's no infection, then there's no issue at all. So, just like Doc said, we have to take our IPC seriously so that we don't even end up with the infection in the first place. And when there's an infection, it is very important that we identify the organism that is responsible and then target it appropriately. And as she also added, data is key in all this that we are going to be doing. Without data, we don't know where we are and how far we are from the goal that we have set. So thank you all for that input. Today we will not waste time. We will go straight on to the next presentation, which is we are going to be looking at our treatment guidelines. I was very happy yesterday that Rich presented this work already started. And the plan is to have AMS teams in the various departments. And these teams will come up with treatment guidelines in terms of antibiotics that will be used and who is to prescribe what and the authorization and all that. It's really impressive. We are happy that we already started on that journey. Today we will delve a little deeper into how we are going to make this work. So I will invite Madam Joyce Amponsa to have that presentation. Thank you.
Thank you very much, Madam Edna. Director and everyone, morning. We are happy to be here today. The training is to strengthen our DTCs and then reducing antimicrobial resistance. One of the things that help us to be able to reduce antimicrobial resistance is adherence towards prescription standards. And one of the tools or the guide is what? Treatment guidelines and then protocols. All the prescription that we write, we do at the facilities, is supposed to be based on these protocols. So I want to know from us our experience with the usage and then how we can link it to the reduction of antimicrobial resistance. Dr. Robe, please share your experience with it. And then, when I mentioned Dr. Robe, also entered.
Okay, so my little experience is learning from my senior colleagues. These guidelines help us to use like an effective use of drugs pertaining to particular condition that we've diagnosed on the wards, and then it's kind of cost-effective, diagnose specific, and also patient comfortability. For example, let's say you are treating a condition that you've not even diagnosed yet, you are prescribing some expensive drug for the patient. So this patient goes to buy, and later on you revise the diagnosis and the patient has to buy another drug. So patients kind of feel so comfortable for misdiagnosing first and also buying an expensive drug. So the guideline help us to effectively get the diagnosis and also use appropriate medications for the patient.
Thank you very much. Let's clap for him. Appropriate medication. So Dr. Brewer, this one is to introduce yourself.
Yes, I'm Matsukwama, head of clinical services. Thank you.
Thank you. You're welcome. Yes, so we'll quickly go through this. So this will be the outline. Hospitals as a critical component for global AMR problems, 6 institutional interventions, defining treatment and then clinical practice guideline, role of treatment guideline, antimicrobial optimization, examples of treatment guideline, then the core features that make a guideline fit for purpose. Yeah, so yesterday we understood by the presentation we had, the first presentation, that the burden for AMR is very huge, it is very dire, and it starts with the hospitals, although we feel that sometimes it's from the community. And why the hospitals? Hospitals because in the hospital we have a dense population of patients that require a lot of invasive procedures, and as they undergo these invasive procedures, the likelihood to put them on antimicrobials is also high, and the more we use it, the more these patients develop resistance to the antimicrobials. And it's also a gateway between the community and then the tertiary care for spread of resistance strain. So in the hospital, we have to look at the prevention and take it as a serious thing to do. Mechanism for the amplification, selective pressure from prescribing. Yesterday we got to know that it's important to do the culture and sensitivity test first, but in most cases we don't have that infrastructure or it's not readily available. So people tend to prescribe, or prescribers tend to prescribe broad spectrum antibiotics, and we know the effect of that as well. And then we have the cross transmission pathways, the proximity of patients to patients, and even those with resistant organisms also spread via staff and then patient or patient to patient, so it also amplifies the rates of AMR. Then we have high-risk populations, such as those who undergo, I mentioned earlier, the invasive procedures, and then the immunocompromised, the frequently exposed to these invasive procedures that I mentioned. The burden in terms of the cost and then the people that die, I think yesterday it was presented, so I will not belabor the points here. Institutional interventions against AMR. We have 6 key ones here. We'll take them one by one and go through them. Infection prevention is very, very key. For IPC, we all know from WHO, it talks about the 5 moments for hand hygiene, especially when we are providing care to clients. And when we do hand hygiene compliance, we realize that most of the times we do not adhere to these 5 moments for hand hygiene. Can we remind ourselves with these 5 moments for hand hygiene? Can we? Yes.
Before touching patient surrounding, before a procedure and after a procedure.
So you mentioned 3 partially. Yes. 5 moments for hand hygiene.
Is before and after touching the patient.
That gives us 2.
Yes. Then before touching a patient's environment.
Like she said, so that's 3.
Then before any aseptic
procedure, that's 4. The one that we usually wash our hands immediately. After body fluid,
coming exposed into contact with body fluid.
Thank you very much. Let's clap for her.
So one of the things we do for compliance with this hand moments hand hygiene is 5 moments for hand hygiene is the compliance observation. So when you go to a unit and they are providing services and you observe, you realize that most of the times when we are going to tell the patient, we don't wash our hands or we don't observe hand hygiene. So this one you can easily do it with alcohol hand rub, especially when your hands are not visibly soiled. But we don't do that often. Mostly after touching the patient, we may wash our hands depending on what happened. If we feel that we were exposed to body fluid, yes, we wash our hands. But afterwards, we may not do that. So it's important that if you want to break this chain of transmission, thereby reducing antimicrobial prescription and all that, and also reducing AMR, that means that we have to take hand hygiene seriously. It has also been observed that it can reduce close to about 70% infections when we observe it appropriately. So hand hygiene compliance is very key. Isolation precautions, that's contact, droplet precautions, and then airborne precautions is also very important to break the chain of transmission. Auntie Edna mentioned that if you don't get the infection, then there will not be a need for antimicrobial prescription or administration. Therefore, the resistance also will not be there. So let's look at the prevention, very, very important. Let's take it. And the surveillance of hives, that's healthcare-associated infections. Mostly, it's very high with invasive procedures. We have cervical site infections, we have CLABSI, that's central line associated bloodstream infections, we have catheter associated infections as well, COTI. So all those ones we need to observe, put a surveillance on it and see how we are doing with it, and then give feedback for people, for us to be able to improve on the infection rate. The environmental cleaning, very, very important, but it's something that we have relegated into the lower level cadre of our organization, and the supervision is also very, very poor. This morning, I know this room, we don't provide clinical care here, but most of us who come are also from where? Our various departments and units. So as we come and we touch this door, it becomes on a highly, we call it frequently touched surface. So it becomes a very dangerous knob to touch. And now I saw the cleaner cleaning, I didn't see him cleaning the doorknob. So I called me and said, what do you use to clean this side? So they don't have anything, especially the glass, they don't have anything. I said, that door you see that everybody that comes in will touch it. So they said, be there and everybody will be picking it and they will be spreading it. So it's important, ideally, every 2 hours, that door is supposed to be cleaned, the doorknob, but we don't do that. So the supervision at our various departments for cleaning must be done very well. Same way with the reuse of instruments for invasive procedure, whether wound dressing, whether for surgeries, CSSD. Yes, we did some baseline assessment or sterilization here, and you're already on board for upgrading of our services for CSSD. So I won't talk much about that. I know we are working on it seriously to improve. The drug therapeutic committees. Who are the members here? Okay, great. So already you are doing something. I just want you to share what you've been doing as a DTC member. You are one, right? You are not.
Yes, the chairmanship has been taken. I brought my services regarding that comment yesterday. I'm not the secretary.
The head has also taken that responsibility fully.
He's fully on board.
Okay.
Thank you. The DTC, apart from what I enumerated yesterday, also is keenly concerned about our rational use of medicine service, doing the analysis and then dissemination of the findings. Currently, our biggest challenge is to do with the antimicrobial prescription, particularly antibiotics. It's a bit on the high side, almost 40, as against the WHO recommendation of about 20. We are also challenged with generic prescribing and then prescribing using the EML. So these are the ones that we are currently trying to address. Our local formulary was taken, we took into consideration
consideration the existing medicines list of the facility, then the EML, and then we try to develop a rich specific one which has been developed, but the adherence isn't yet the best. Thank you.
Thank you very much. Let's start for DTC. Alright, so we are already doing a lot. Develop and update the facility antimicrobial formulary. Said that it's done, or you are on it? It's done. That one is done. You said it's a general one?
Yes.
Okay, great. Commission quarterly antimicrobial use surveillance report. We do that. The second point here, commission quarterly antimicrobial use surveillance report. You haven't done that. Okay, so that is the essence of this meeting, to strengthen DTC activities. So let's take note of that. Antimicrobial use surveillance report is very key. And then okay, yes. All right, but we disseminate it to the prescribers and all that. Okay. Performance reviews. That's the one. Okay, that is the quarterly, per half year, annual. Okay, thank you very much. So for quality improvement, Dr. Brahma is here. The prescribers, they are not adhering to so if we want them to improve, we are disseminating this information to them quarterly. That's what we've been doing all the time, and we are not getting the result that we want. Is there any other way we can use to help?
Yes, please. We are not only looking at our prescribers who are already here, but anytime we get new prescribers, anytime we get house officers joining us, we also organize orientation programs. Pharmacovigilance and REM activities are also part of the dissemination.
Thank you very much. How often is this?
This year we've already had two. Yes, please. When anytime we get the new ones.
And then so I'm just looking at the frequency of dissemination. We hold the clinical meetings how often? Is it weekly, 2 weeks? Clinical meetings?
That department is, some department do every morning.
Oh, okay.
Often every day, some once a week.
Okay. Okay, I've seen a hand. Let me go there and then I'll come back.
So for the antibiotic usage, we normally take data from family medicine. So we have been disseminating the results most often with the family medicine when they have their morning meetings. And we get that data ready every quarter. So in fact this year we are yet to disseminate the first quarter. We have disseminated last quarter to them. And so we are planning to disseminate first quarter, which the results are ready, because we get it ready every quarter. So with family medicine, is something we do regularly with them. The head of department is here.
Thank you very much. Yes.
Thank you, Rich. You are doing very well. But just a point of correction. When the second point she was referring to antimicrobial surveillance reports, we do appreciate the RUM survey you do and the reports that you disseminate. But this one is a little different. This is not the RUM. But we will talk about it. The next presentation will actually detail about it.
Thank you. Thank you so much. All right. So the review of antimicrobial related adverse drug reactions. I think yesterday it also came up. Approved empirical treatment protocol for local antiviral data. Yesterday we had a presentation and Dr. Banini mentioned it. I don't know whether our lab is able to generate the antibiogram for us. Do we have it?
We don't have think it's doable. They can always be here for it.
Okay, so the lab was here yesterday, and I believe he has taken that. Oversee the facility MS team work, plan, and then target it. So the facilities antimicrobial stewardship team should work under the DTC. Is that the structure we have? Okay. And then coordinate prescriber training and CPD on AMS principles. So with the gap you mentioned about non-adherence, I think we should work together with KY to see what is contributing to the non-adherence, develop change ideas and test them and see how it will come out, so that at least we'll be able to improve on that going forward. Another intervention is institutional formularies, which I think I mentioned it, and we have some here. We all know about the AWARE, Access, Watch, and then what? Reserve. So we know about that already. Therapeutic substitution and delisting, all that I believe we do it as well. Microbiology, a lot was said about this yesterday by Dr. Badini, so I will not belabor the point, but just to mention the turnaround time standards, timely results enable de-escalation from broad to what? Targeted supply. So that is very, very important, so that we prescribe medicines that are what? The targeted, not the broad spectrum, to reduce the AMRs that we intend to reduce. So antimicrobial stewardship, we need to take prospective audits and feedback. The feedback is very, very important. That's what I kept on asking, how often we disseminate to the prescribers. The quarterly for me, I feel is still long, but if you are internally, you are here, you know the things that prevent you from doing it timely, but let's look at it. So the real-time feedback is important to prescribers. And then pre-authorization, watch and reserve antimicrobials require a sign-off from designated AMS lead or DTC before dispensing it. And I know as DTC members and the prescribers, they know about this. Prescriber education, very, very important. We have to take it seriously. So let's work on the frequency of the education that we intend to have. Use of clinical practice or treatment guidelines. So that this is a bridge to the rest of today's session. And we want to examine the treatment guideline in depth, what they are, the role they play in antimicrobial optimization. And I'm happy that it's not a new thing to us, so we'll just run through quickly. When it comes to systems, so they don't work in silos, they are interconnected. So if you want to reduce AMR, there's a need to work together. These things that we are going to mention, the IPC, DTC, formulary, the laboratory, the AMS, and then guidelines. They are not supposed to be used in silos, but they are interconnected. Each intervention strengthens the other. The lab data sharpens guidelines, the DTC enforces formulary, AMS audit adhere to guidelines, IPC reduces the burden, and then helps with the management of the guidelines as well. So what are treatment guidelines? I think Dr. Roby mentioned something. No, this one. The one here. Dr. Dr. Roby. Okay. So I'm talking about Dr. Roby. He shared his experience with the youth this morning. He said that the systematically developed statements that exist practitioner and patient decisions about appropriate healthcare for specific clinical circumstances, recommending what should be done, by whom, when, and then how. It translates best available evidence into clear, actionable clinical recommendations. And it helps to standardize diagnosis, investigation, and then treatment decision across all prescribers. Because of the treatment guidelines, when it helps with diagnosis, so it prevents personal decisions. It standardizes the diagnosis and then the treatment that is supposed to be given. So, irrespective of where you are, irrespective of the facility, we all go by the same standard. So it specifies first, second, and alternative line antimicrobial choices by indication, and it is applied at every level, right from the lower level chiefs up to the tertiary levels. What does it typically contain? We have the diagnostic criteria, we have the first-line therapy, escalation pathway, special populations, monitoring parameters, then referral criteria. So it's a form, a guide, I mean, just like the name, it guides the practice, it guides decisions that we take concerning the person, the diagnosis, the kind of treatment to give, and all. So the role of the treatment guideline in antimicrobial optimization, so the right choice, very, very important. There is a need to systematically select the antimicrobial so that at the end it will help us to reduce the resistance as much as possible. So the right choice, the right dose, and then duration, it helps reduce variations because it guides your decision taking based on the diagnosis. And the resistant containment, built-in escalation or de-escalation logic, and watch reserve restriction to protect last resort antimicrobials. So it also reduces what guesswork and helps with precision therapy. So indication for the drug that you are given, it guides you to do that. It standardizes the dosage regimens, because when it comes to AMR, the dosage, right diagnosis is very important. The right dosage is important. The right route is important. So the guideline is able to guide us to do this, and even the right duration. If you don't give it at the right, you take it the whole duration that has been given, it also contributes to it. So the guideline is able to guide us as to how to do all this. Reducing variations containing resistance. So it's a benchmark across prescribers, irrespective of the levels of the facilities you go to, depending on your diagnosis. When you use the guideline, it prevents variations. De-escalation logic, guideline instructs when to step down from broad spectrum empirical therapy once culture results return. It also helps with the gatekeeping system. So we look at the watch and reserve as well, so that we prescribe the appropriate antimicrobials at appropriate time. So we have some examples of the treatment guideline. We have the aware antibiotic book that will tell us the classification of the various antimicrobials, the one that we have access to, the one that we have to watch, the ones that we have to reserve based on the type of antimicrobials they are. We have the WHO essential medicine list. We have the standard treatment guideline. We have the essential medicine list. So all these ones are available to guide us to make appropriate diagnosis and then prescription. The WHO Aware Antibiotic Book is a pocket reference providing agent-specific guidance on indication, dose, duration. The aware is access, watch, and then reserve rationale for common infections. It's organized by clinical syndrome for rapid bedside reference. And I think every prescriber knows about this. Dr. Bobe, are you aware of it? Yes. So I will not belabor the point here. WHO Essential Medicine List 2 is also available that we use often, and it's updated by the WHO Expert Committee every 2 years. I think Ghana, we also have some that is used for 3 to 5 years, also is updated every 2 to 3 years. What is the current year that we are using? This is still 2017. Essential medicine.
Yes, I think so.
Okay, so the standard treatment guideline is updated 3 to 5 years or sooner if resistant data warrants it, informed by national AMR surveillance and local antibiogram data. I think it's a guideline that you find in most consulting rooms, and our prescribers refer to it most of the times to make their prescription decisions. Same with the essential medicine list. There's some treatment guidelines, some of the features you will see is developed by experts, is evidence-based, is cost-effective. I know with the cost-effective thing, somebody was saying some time ago that, oh, when you go to the hospitals, the drugs they prescribe are cheap. Forgetting that those drugs also work perfectly, that like the ones with some brand names and that we know about, they're very expensive. And myself, it even happened to me, we give it paracetamol. When I want to buy it, I will say, oh, I want the foreign one. Until somebody in the pharmacy school, a student, she was doing some, I think they do some research or something like that. She did an essay on different brands of paracetamol. So she did the foreign ones, then the local ones, different names. And then at the end, she said that, oh, they have the same active ingredients in it. So it's like, if you even buy the foreign one, how the local one would have worked is the same thing. Maybe that you will spend more if you don't have this knowledge. You spend more for the same effect. So, yes, you go to our facilities, maybe the hospitals, before they procure, they also go through, I think yesterday came out that Ghana Standard Authority of Drug, FDA, yes, will take that sample and then work on it and approve it before it comes. And then at the facility level, the DTCs also is their responsibility to also check these things, isn't it? Yes. So whatever is taught at the hospital level, the health facility level, it has gone through the process for us to know that it can work. That's why they have been put there. So that notion when some patients feel that, oh, the drugs at the hospitals are not effective because of the cost of it, we have to educate them on it, and then for them to be able to know that yes, it will also work as the other one that is more expensive. Aligned to WHO model EML and aware, regular updates we know about that. Clinical management algorithms are also part of the sound treatment guideline. So for our takeaway, quick one, we say that the hospital are high-risk amplifiers of AMR. True or false? True. Why do we say so? Why do we say so? Because of hospital-acquired infection. Yes, it's because the patients come, we have a lot of patients with different types of organisms coming in, and we also do a lot of invasive procedures. So if you don't observe hand hygiene, then we are going to have more infections, and more infections means what? More antibiotics, and then resistance as well. And then we say IPC and DTC formularies, lab, AMS and treatment guidelines work as one connected system. We shouldn't work in silos. Yesterday I was asking the IPC focal person here whether she's part of the DTC, and she said she's not part. Is that the case? Yes. IPC. We are working on the team formation. The numbers. But this is very important. We need to work together. So let's get, I feel strongly that you should be part of the team. So we have the IPC, the DTC formularies, lab, AMS, and the treatment guidelines work as interconnected system. Treatment guidelines convert national policy and evidence into consistent day-to-day prescribing, and then a credible guideline is expert-developed, evidence-based, cost-effective, aligned with aware, and then regularly updated. So we should trust whatever we see in it. So this brings me to the end of this presentation. Please, is there any question, contribution, or takeaways?
Within the region that you can recommend that we can also go in there. Nobody, not the DTC. I don't think the background to what. And I've heard about Legma that they do a lot of things
So in terms of AMR, and then there's stewardship. The Letman, we will take us through it. But they are doing a lot of things. So I mean, on top of my head, I can mention them as a facility that we can also visit to learn about what they are doing for AMR. So we'll take the second presentation quickly and then we'll move on. Okay. So the second one of this is related to what we just discussed anyway, institutionalization of DTC AMS programs. So we want to look at what is stewardship, what is AMS, strategic objective 4 of the Global Action Plan for AMR, component of AMS, and then composition of an AMS team. When we talk about stewardship, I want someone to explain this or say something about this. Stewardship. And say yes. What are you thinking about?
It's how well drug as so I think it has to do with how well or how appropriate it is used.
I think she said most of it, but maybe being a caretaker is a word that comes to my mind.
Thank you very much. So it says that if you look at the definition, it says the careful and responsible management of shared resources. When it comes to drugs or antibiotics, they are finite. I remember yesterday when Mr. Isamawena was doing the presentation, he showed a slide that previously there were a series of researchers that came up with a lot of antibiotics, isn't it? But up to some of the years it has reduced, meaning that if we don't protect what we have, we don't reserve it, and then watch it the way it's supposed to be done, the time will come that, just like we are experiencing now, we develop the resistance and there is no more antibiotics to solve that issue. So we as caretakers now have to do things to make sure that we preserve what we have. Just like in the Bible, there's a story about there's a good steward there, where Jesus was distributing the gifts. Somebody used theirs, others also just kept hers, and then it means that causing financial loss to the master. So we have to really have a good stewardship over the antimicrobials. The burden again has appeared here. We talked about it yesterday. But if we relate it with the cost of it, it's a lot of what money is expensive. If somebody gets drug resistance, very, very expensive. So it's important that we work with infection prevention, vaccination, and safe disposal to avert this burden that we have with antimicrobial resistance. And we also yesterday mentioned the One Health approach and look at how they are also connected and what we as individuals can do about it. We talk about the human, we talk about the environment, we talk about the animals. And some practices that are ongoing now that is also affecting all of us. So if you are close to anyone who is doing such a practice, or you yourself, you are involved, we also have to be a good steward and make sure that we help reduce this burden that we have with antimicrobial resistance. So what is AMS? Antimicrobial stewardship is a coherent set of actions that promotes the responsible use of antimicrobials to preserve their effectiveness. AMS is not about restricting access to patients who need treatment. It is about ensuring every antimicrobial decision is the right drug, right dose,
right route, right duration for the right patient. So, this right, I think for nurses they have about 12 rights. But this one is emphasizing the right drug, right dose, right route, right duration, the right patient, about 5, very important. So it ensures every antimicrobial decision is the right drug, so we mentioned that, and the fact that it's not restricting the use is also here, so we'll continue. So what AMS program set out to achieve? One is to improve clinical outcomes. Yesterday, before the presentation, Madam Edna showed the vision for Ghana Health Service. Can you remember? Do you remember the vision for Ghana Health Service? Anyone who can mention it? Anyone? This thing is very dear to my heart too, because I think I don't get it that, we are working with an organization and we don't know the vision for the organization. It hurts me because I've been to a program before, and excuse me to say this, even in quotes, a driver was able to articulate the vision of that organization and how he was able to link what he does to achieving that organization. I was so shocked. But when it comes to Ghana Health Service, everywhere I go, I keep asking people, what is the vision for Ghana Health Service? And it's always a challenge. Somebody can even tell me that, when we are going for interview, we learn it. And then after the interview, that is it. But it's important that we get to know. So yesterday we said that it's what all communities having access to what? Timely, quality, and comprehensive health care. Okay, so if you are talking about improved clinical outcomes, it's related to our vision. And if people are developing antimicrobial resistance, the person has come to, it's not, or maybe has some surgery performed and we give antibiotics, it's not working and all that. Are we meeting the person's need? Expectation? Are we meeting the person's expectation? No. So in that case, we are not providing quality care. So if he says that we want to improve, the program, AMS program set out to achieve improved clinical outcome. Yes, very true. Minimize resistance selection, very true. Reduce avoidable cost and harm. We want to reduce it as much as possible. Some from principle to program. So the stewardship as a principle. It's a global thing, cross-sectorial approach, and applies to any shared or finite resource, guides national policy and GAP and AMR. No single owner, it's a team approach. Then when you bring it as a program, it's a facility level, structured program. That's why all facilities, especially hospitals, we are supposed to have it here. And it's owned by a designated AMS team and then the DTC. So what it means is that we have the big DTC team, and then within the team we can have what? The AMS team as well. Chief, performance. Is that what we have here? Aside the DTC within, we have the AMS team as well. We don't have the AMS team in the subcommittee, yes. Structure here in Greater Accra Regional Hospital, that is great. So personalizing stewardship via audit, policy and education is key as a program. Reports measurable indicators to hospital leadership. So that's what you said you do quarterly. DTC team, you do that quarterly. Hey, are we here? I need you to follow this because this is more of the DTC and then the AMS. Alright, so how AMS programs operate day to day. Prospective audit and feedback. Real-time review of active prescription with non-punitive feedback. I remember yesterday you made mention of this, that in case the prescriptions are reviewed and you want to engage the prescriber, it should be done in what? A free atmosphere, isn't it? So can you share a bit of experience from your end? It's like all the questions are coming
Where are the other members?
Once a soldier. Thank you. I must say that generally, when we pick care issues, the prescribers are receptive. You go to them, you discuss. You never know what intentions he also had for prescribing a certain medication. So it will be out of the way, or to be inappropriate to just sit somewhere and say that, oh, this is not the right thing. Go to the person and discuss. Sometimes when you go, you also tend to side with him. But most times, they are very receptive. You discuss the issues alongside current guidelines and references, and it is acceptable. And they will come back and we do the changes. But on a few occasions, some may be very arrogant. For example, about 3 weeks ago, we found a prescription for 150 milligrams of diclofenac injection start. So for diclofenac, the maximum is 100. If you have any reason at all, maybe you can go half in the morning, then so you have your 150 ceiling. So one pharmacist was detailed to follow up. Doctor, do you think we should give all the dosage at a go? We don't think it will be proper for the patient. So can we divide it or do something about it, or probably look at combining? On the analgesic ladder, combinations are also allowed. Only that you go down on the doses if you are combining, let's say, paracetamol with an opioid and any other thing. And know what the answer was. Do you want me to hand the patient over to you? So, dialogue is key. Good communication. You know, the way you communicate with people is the same way you are likely to communicate with the patient too. If you are communicating to me, a team member like that, then I wonder what will happen to the poor patient who doesn't even know how to articulate whatever he wants to say. So I must say the relationship is cordial. We are doing our best, but change. There was a time I found a prescription, not here, elsewhere. That medicine is solely used in women at the gynae lab, at the gynae ward. So when I saw a prescription for that particular product for a male, I got alarmed and followed up. And the doctor was like, oh, in 19, so it used to be part of a cocktail that we were given and it was working. He said, we can't take responsibility for this one. Things have moved on. Those 19 something things have changed. Can we just, no. I said, then I won't apply for my pharmacy because I will not do it. They said, you have to prescribe it for the patient to get from outside. The following morning, the nurse was also there listening. The following morning, the nurse came to me and said, the patient passed on. In this work, whether we like it or not, people will die. It is natural that when you grow up to a certain stage, you will die. If you got an infection, you don't manage it well, you can die. Even hypertension, diabetes, chronic conditions kill people. So no matter what, some will die. But it is very, very unfortunate if we should just be the accelerators of that death. People will die anyway, but let us prevent the avoidable ones. Let's work as a team. Communication is very key. And then those of us who also go, the approach is also very key. You don't go rising your shoulders like you are on top of the world and you know everything. Nobody is a reservoir of knowledge. That's why CPDs are there. Thank you.
Thank you very much. Let's clap for her. Oh, the clap too. Yesterday we didn't have time to do something. Our IPC trainings, we have a club, we call it IPC Club. And there's a reason for that club. when you Google right now for benefit or health benefits for clapping, you realize that one of the benefits is to reduce, okay, let's say improve circulation, okay, and then another one is to improve the antibodies. So when your antibodies is improved, what will happen? Your level of infection also reduces. So it's able to reduce infection rate. And the clap is very simple. Pa, 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 pa. The last one goes to the person. If it's for all of us, the last one comes to us. Can we try it? This one for us, yes. So yeah, thank you. So yes, thank you very much for sharing that experience. It's important that we have this real-time review of what active prescription, and then we intervene as needed. And also prior authorization for the reserve and then the watch antimicrobials is also important. We need to get a sign-off from the responsible person before we dispense that as well. Guideline-based prescription. So like the example you just gave us, that somebody was mentioning 19-something drug. If the person, because whatever it is, the treatment guidelines have been updated. If the person was going or adhering to that SDG, I don't think they have prescribed those drugs. Or what do you think? And then prescriber education, that is also another key. Prescriber education over and over again. So it brings me back again to the same question, that the quarterly dissemination and then the education, still I feel that we need to improve upon that. So let's find an innovative way of doing that and then educating them often on what is expected of them. The strategic objective 4 of the Global Action Plan and AMR talks about equitable access, appropriate use, and then safe disposal. So in terms of equitable access, reinforcing supply chains, forecasting, and resilient measure towards universal health coverage. So we know the consumption pattern of whichever drugs that we have available. Forecasting it appropriately is very important so that we curtail the issue of non-availability of these medicines at our health facilities. I went to one region, a hospital, and a client said, when they are sick, they don't even come here often. They don't come because at the end, after going through the queue and then get to the pharmacy, all they will do is to do what? Write for you to go and buy it. And the person was telling me that you go, I can take you to a pharmacy here. You go and see the queue there. So why should I come and join the queue here and at the end get a prescription to that same pharmacy? So next time what will happen? I will go there straight away. You see, so it has reduced the attendance in that facility. So it's important that we do the forecasting very well, we do proper supply chains, and then make sure that the needed antimicrobials that we need, because over here we will go through all the check and balances to make sure that the drug that we store are also appropriate for them and it's also cost effective. So let's have that done very well. The formulary, we have mentioned it, having market intelligence and strategic sourcing. Pool procurement is also, here is a big facility, so in terms of procurement, we know what we do. Particular attention on smallholder farmers and conflict-affected settings. Appropriate use is also important. And what guide answers what we discussed earlier about having the guidelines. So we have the MEL, we have the SGT, we have the other guidelines that are available to guide our diagnosis and then appropriate prescription. So the need for workforce capacity must be strengthened so that our prescribers will do the needful all the time. Safe disposal, that's also another key thing. And I know that when it comes to drug, the medicines that we use in our facilities, when maybe they expire or maybe we realize that it's not working as it's supposed to do, there is a guideline on how they are supposed to be disposed of. True or false? True. Okay. So DTC members, the pharmacists, who else aside Chief, who else is here? You are quite. She's. Yeah, so we are waiting for her to tell her what she does. Okay, so we'll come back to you. So for the safe disposal, we know that we have a guideline and then the way it's supposed to be done. For waste, let me say this. I think at the pharmacy, when it comes to waste segregation, we said that the pharmacy should use what brown, bin, and then liners, isn't it? But we really use it at pharmacy. Somebody, I think just last year, the person told me that, oh, we don't use that, we use boxes. When the drugs are expired, we keep them in boxes because that's what is happening, right? Until now you have remembered. Please, I'm told you are the experts for safe disposal of our medicine. So can you share your experience? What's supposed to be done with us?
So thank you. Expired medications, what happens is that if some medications are found to be expired, either at the dispensaries or at the stores, we have to quickly remove them from the shelves. Then that a board of seven has to be constituted by the management to inspect the products. So the audit team will come and look at the products, and then a list is made. So what happens is that normally it's sent to, we have to keep it in a designated area, and then we call the FDA officials to come and do the inspection, and then after that it has to go for the destruction. So currently, if your incinerator is working, they have to schedule a date where the FDA officer has to be there when they are doing the destruction. And after that, they give you the certificates to prove that the products have been destroyed. Yeah.
Thank you very much. Let's clap for him. Hey, remember you are working on your heart. Let's do it. Yes, we want to improve our heart circulation. All right, so when these drugs, especially antibiotics, which are expired and about expiry, somebody told me that when they ask for the dates, they are just there. Though the dates may be, let's say June, and the thing is, so it doesn't mean we can't use it. You can use it for 6 months. So let's say the antibiotics are expired and they are not disposed of like the way you described it, according to the guideline. In relation to antimicrobial resistance, what will happen? Want to share something? The way I saw you shaking your head. I agree. Okay. Want to say something?
So, first of all, I think expired products can be harmful to us, and there is the reason for the expiry. It means its potency might be reduced. Yes. So those are.
Thank you.
I think if we don't dispose of them when they are expired, the risk of resistance to increases. Yes, because you can contaminate our water bodies, the soil, and everything. Then eventually the whole society gets affected by that.
Thank you very much. So I've already talked about this relationship about One Health, the environment, animals, and then humans, and then so the effect this environment will have on us in relation to antimicrobial resistance. So for the diagnosis and regulation, again, we talked about this yesterday as Dr. Banini was presenting. There's the need to expand access to quality diagnosis. And she emphasized on this yesterday so that we'll be able to detect infections early and put in the appropriate measures to break the transmission cycle. Regulatory strengthening, it also mentioned yesterday about a lot of practices in our community now, what we can do with the FDA and all the other agencies that are supposed to work on this. So in terms of development, manufacturing, distribution, use and disposal, we have ways or guidelines for doing this. Curtailing substandard products. I think yesterday it also came up and we had a lengthy discussion on that.
So component of AMS, you have leadership commitment. And medical director is out now. But at least since yesterday when director handed over to him, he's been here. I think yesterday, the whole day he sat through. This morning he has been here. And the management members are also here. It shows the commitment of supporting this AMS team. Let's look at what they are supposed to do. Formal recognition of AMS within the hospital governance structure is very key. So currently our governance structure, when we have where the pharmacy is, do we have DTC there? I haven't seen your organogram. Do you have DTC under the pharmacy?
No, please. DTC is
Universal. So in terms of this, what can we do? Formal recognition of AMS within the hospital governance structure.
Thank you. So DTC is not a pharmacy, but then it has this mandate of regulating activities as far as drugs and therapy is concerned. So the decisions of DTC is recognized by management that it has this power to ensure that this list is available, these medicines are available. If it's used and there are challenges, those challenges are resolved by the committee and management accepts it as a governing.
Reporting lines as well.
Exactly. So its reports are reviewed by management or is given to management for implementation recommendations. Yes.
Thank you very much. I want to say this before I forget because our regional boss is here. Chief, regarding expiry, like she said, it's withdrawn from the shelf. Now the challenge is with the disposal. We first constitute a board of survey. FDA comes to inspect. You go there, make payment, take a receipt. You come to wait for them. Currently, we have a quantity of expired medicines there. We've been struggling since last year to get them disposed of. Now we've paid the appropriate fees, and they have referred us to a private vendor. And the charges of the private vendor just too huge for us. Because we've already lost by those items as get here. So if I have to pay, say, 10,000 to get medications that have expired, it means we are losing twice. So we decided that we will not use a private vendor. At that time, we had issues with our incinerator. Now the incinerator has been restored by management. Now we go back to them. She's coordinating it. And I hear our incinerator is sited close to WAEC. And every time we burn something, the smoke enters their compound and it disturbs them. So they are insisting that it should be done in the night. Now I'm not getting FDA officials to come here deep in the night to come and help us with the disposal. So I wanted to make an appeal to the region. If you could collate, if you could write letters, bring the letter that you have so that you do it in bulk for us. Then this burden of private vendor coming to collect. Other than that, if it is something small that I can go mostly dig somewhere and hide it, the temptation to do it is quite great. Understand in a certain facility, they wanted to erect a new building, and when they dug the ground for the foundation, bottles and infusion bags and other things started popping up. If you want to avoid these things, I think there should be a central point where we can be instructed to bring the expired medication so that the region can look at it holistically. It's an appeal, please. Thank you.
We have a sanitizer around. The use of the mic.
So thank you very much. I think your proposition is in the right direction. But just like you said, when you collate all these expired drugs and they become, excuse me, too huge, then the private vendor will also charge so much. So in a quarter, the little that expires, while the facility has an incinerator, you can just go through the process and get it done. When you wait and you become bored, then the charges and everything also go up. Actually, it's not all the facilities that have the incinerators working. Actually, that's it. So a place like where you have a good incinerator that is working. But unfortunately, the comments like the smoke going to a different place and all that is quite harmful. But where it's cited is for that purpose of incineration. And that's the best way to go because it burns everything to ashes and it least contaminates the environment. So I don't know how bulky what you have is, but if you can also do it in smaller pieces so that, or batches, so that the time you are incinerating, it doesn't produce so much fumes to contaminate the air. But they are making the money so they have to come. But your point is well noted, so we'll look at it.
Thank you.
I know the disposal for the cytotoxic plants are different, so I'm just going to touch if Rana was around. Initially, there was some challenge. I don't know whether she's not on the paper when she comes.
Thanks so much. So, yes, with the incinerator, your home, is it the double chamber type? And then the chimney, how long is it? Is it a short one? No, it's long. Okay. So maybe, has EPA looked at it before? Assessed it? It's certified. It's certified, all right. That's okay. Great. So, talking about as the governance structure is something, a team that the facility or management should be aware of, just like you described it. That there should be a time allocated for AMS teams members to worship duties. Do we have a dedicated time to work as such? Team members, do we have dedicated time to do AMS activities? Oh, I want a response. There should be time allocated. So we are talking about leadership commitment. You should have a dedicated time. You use your normal time. So it could be let's say you do your 5 days in a week. Maybe 1 day out of the 4, you decide that this one is dedicated to AMS activities. We don't have. But do you think it's something doable that can enhance our activity, looking at the roles and responsibilities that we have? Okay, please let's take note of it and then work on that. So it's part of the leadership commitment. The budget line for stewardship activities. I think yesterday it came up here with the support, financial support for activities. So, and again with that one, it means that the team, the subcommittee is looking at their prioritized activities they want to undertake, should have a budget line attached to each of them. And then when it gets to when as an organization we are developing our plans and budget, it should be part of them, it should be sent to management to be part of the composite budget. Yes, if we don't do it like that and then later on we are doing an activity and we write memo that we want this amount of money, it becomes difficult to dispense that amount of money. So let's plan and budget towards those activities as AMS team. Yes, but Kata can say, please, share what we are supposed to do with that in terms of budgets. Can we just come with memo to say that we need this money to do this activity, or we need to plan a budget for it?
So first of all, have a plan activity, and the plan should be approved, and then it can be translated into a budget. Even when it's done, we start to review it periodically, so that we see that it can be the activities of the whole program. Thank you.
Thank you very much. So this one also, it's for everybody. IPC, quality. Sometimes you say that, management is not supporting us, but we ourselves are not developing our plans and budgets. And don't assume that, they should know that this activity should happen. But we are responsible. So let's outline those activities. Plans, that's your action plan. You have to cost it. Sometimes some of us, when we prepare the action plan, and then the costing part, we just put a figure there. Without the detailed budget, you should get the detailed budget that will get you the total budget that you put there. If you don't do it like that, it becomes difficult for management to support when the needs come. AMS performance review at senior management and this TC level. So she mentioned it earlier that you do performance reviews and then you look at your performance as well. So that is good. Accountability. A single named individual or co-leadership team is formally responsible for program outcomes and reports through the DTC. So it's a subcommittee, so that leader reports through the DTC. So you should have a designated AMS lead. Please, do we have, or so we are now forming the team. So we have the subcommittee.
Yes.
So we have a lead.
Yes.
Okay, great. Then clear terms of reference. Do they have that? Clear terms of reference. They are now developing it. Okay. That will be shared across the team members and the DTC. Regular reporting of AMS indicators to the hospital leadership should also be there. Define consequences and escalation pathway for non-adherence. Drug expertise, dedicated pharmacotherapy expertise. Typically, an AMS trained pharmacist anchors clinical decisions in pharmacology and resistance data. So pharmacist co-leadership with dedicated authority to manage agents, working knowledge of local antibiograms and aware classification. So the local one, you said you are now doing it, so we have to facilitate that. Capacity to review dosing, renal adjustment and drug interactions, bridges, prescribing, practice with formulary and procurement decisions. So all these are activities for the AMS team. Then intervention and action. Prospective audit feedback, we talked about it earlier. Pro-authorization, we talked about it. Facility-specific protocol, empirical therapy guides from local data. You made mention that you are now developing something like that, a facility-based protocol.
Yes, we discussed it.
Okay.
And this is in connection with the
Yes.
We wanted to get a baseline data on the sensitivity patterns for rich population. And then the lab said their data is gone with the links. They could have pulled the data for us to do the analysis so that we have an idea about the kind of pathogens we are surrounded by. But it's gone with the links. So they are now trying to develop another one so that we can tap into that data and then proceed.
Thank you very much. So those are parts of the activities or interventions for AMS team. And then IV to oral switch programs. When we review the prescription, we can also advise on these ones as well. Tracking and reporting. So the process and outcome metrics are measured routinely and feedback to prescribers and leadership to drive improvement. And I think she kept saying that they do this quarterly, but I feel that it should be often. So QIT will work with them and then we'll see how that will go. Education also came up, we have talked about that over and over. Then the composition of the AMS team. Physician and then IV champion, AMS pharmacist, clinical microbiologist, infection control nurse, data surveillance officer, hospital administrator. Please, our subcommittee, the AMS team, is that the composition? Is there anything missing? Is there anything?
Yes, the administrator is missing. We have one administrator for the whole DTC.
Okay. Can be part of it.
Yes.
Okay. But the IPC nurse is there. All right. So 3 roles every program needs: physician, infectious disease champion, provides clinical leadership with credibility, chairs case discussion, and co-signs pro-authorization decisions for watch reserve agents. AMS trained pharmacists, what the person will do, clinical
infection control nurse have to look at the IPC surveillance data and then take decision based on that. Data surveillance officer also looks at the consumption antibiogram dashboard, which we are yet to develop one for Rich Hospital. DTC and hospital administration team, AMSC reports formally into the drug therapeutic committee, which approves policy and secures resources. So our key takeaway from these discussions, we should have stewardship in the global principle and also as a program at the facility level. GAP AMR strategic 4 looks at AMS as what? It should be equitable access, appropriate use and safe disposal. A sustainable AMS program requires all 6 components working together, which we have discussed. And the multidisciplinary team reporting through DTC is what makes the program permanent. So that brings us to the end of this institutionalization of DTC in our health facility. We are doing well with what we are doing, but we can always do what? Improve. So I'm glad that we've been able to identify where the gaps are, and there's also a promise to strengthen the team and also equip us, management will support us to be able to function as expected. So on this note, I say thank you, and if you have any question or contribution, we can bring it up. Dr. Banini, you're welcome.
Question time. Whilst we take our snacks. Oh, she confused us so much that we have nothing to answer. Oh, she was the best teacher. We understood everything. Okay.
As a clinician, yes, you want to do cultures to be able to make the right diagnosis and treat the patient, but there are times when you can't get a culture done. One patient can't afford, 2 timing, maybe it's in the middle of the night, that won't accept the sample. You don't know whether you're keeping it overnight to submit it the next morning. So I would say that let's come together and make a decision. As you are in Ghana Health Service, can we have things like chemistry, things like cultures, at least for your first investigation? Can it be on the NHIS? Can it be done without payment? We have an electronic system, everything can be built on it. But somehow we tend to face more difficulty now when you need medications for patients, when you want to do labs. There's only 4 blood counts in urinary you can do for the patient. So in the middle of the night, the patient now going to look for money to come and do a blood CS or urine CS, then you miss that window. So some of those things should be part of policy. Within first 24 hours, can we do labs for the patients and build them with it? Can we get drugs for the patients and build them with it so that things can be a bit more smoother than they are now?
Thank you very much. This one is a comment. So, what comment on this one?
I can just comment on it. So, what actually happens is that when there's room for empiric treatment, there's room for direct treatment. So, empiric is prudent, so you don't have to wait for cultures. However, turnaround time for cultures, urine culture, that you have 42 hours. The blood also wait about 5 days, even about 5 days. You cannot wait because patient is sick. And that is not the idea. So what we're saying is that you start empiric treatment, but you have to be guided compliance. You should put your actions are over there. So your concerns are valid. You request the cultures, patient can't afford unless you pay for them yourself, which I don't think we would be doing. So there are times when we maintain empirical treatment, your patient leaves because they can't afford it, and that is correct. The only thing
Our only concerns are that when there are small gaps in the prescription habits, it feeds into AMR. So if we're going to do a lot of medical business, I think across Ghana, about 80% plus is a medical business. Then nothing can do about it. I mean, so that's happening. So we won't wait for the watchers to come. So in essence, that is practice. It will be difficult to defend when there's a problem to see that you're waiting for watchers for attention. So I want us to remember that we're going to treat.
No, as for that one, it's practice. We have our own protocols in place on the first line antibiotics we want to give. My point is that we want to be better at watching, then it should be part of a system. Because I can take a sample to my patient and
thank you very much. But I think now it's an emergency. It can be taken care of, right?
Thank you. So I also want to add a comment to what Dr. has added. And I think this is how beautiful DTCs are. So that we get the expertise from different angles. Yes, it's a practical case. The case is in the night. The lab, I don't know whether they will take the samples even at night and the patient needs care. Maybe it's even an emergency and something is practical. So DTC needs to come up with policies which is approved. I know your policies definitely will be signed by the nurse and stamp that this one is approved for the facility to work with. So in such cases, this is what we do. A, B, C, D is clearly spelled out so that in that circumstances, everybody knows what to do. But like I say, you are the leaders, you are the pioneers in the region. Everybody is looking up to you. So yesterday we were discussing antibiogram. Yes, these are the things when they are available. We can maybe just take the sample, start with something empirical, but then the lab can quickly use that one to give you a quick results for you to work with. So it becomes part of the policy for all possible. Thank you.
Great comments. Thank you very much.
Currently, we have something like that with pharmacy. If it's an emergency, we can at least cost for patient for the first 24 to 48 hours. And if the patient cannot pay within that period, we engage social welfare people to come in and we continue to give the medications for such people.
That's for pharmacy. So, lab.
In actual fact, I'm not from Rich Hospital, so I don't know what really happened in Rich Hospital. But is it? So if it's an emergency that have come, I think Rich Hospital should have a in place. As pharmacy is saying, if you go to GMC, you just make a deposit, then everything continue and
that's not a problem. I'm sure if you're going to a private hospital, you have an idea that, oh, this one is really costly, so you take some money. Yeah, you know something like that. People come in and expect that.
okay, so it's emergency. Can we ourselves have a system in place? I can have $10,000 in my account, but under emergency, I cannot even type a code. Should we have a system that will cater for that? When you come, we do it. And number two, for administering of antimicrobials, that is why we are encouraging that DTC should come up so that we will have local antibiogram. Then when you know the local antibiogram, you can know what to start with as we wait for the laboratory test to come. And I don't know, taking sample to lab, for the lab people to store for their fellow people to come and work on, I don't think it's something difficult. So let's, as a DTC, lab is part. Let's discuss with the lab so that we can see if the night shift can receive
microbiology sample, and it's just a matter of SOP for them. When you receive this sample, this is what you do. When you receive that sample, this is what you do. That's the baseline. I think that was so good. Thank you.
Dr. Ami, so that is a very valid point. And as an identified indicator for the pharmacy, it is working to a large extent for the drugs. And these drugs will be drugs that are available. So if you prescribe outside, then the facility cannot do that. The lab also used to have that. It's something that come back. The challenge has been with the new electronic medical records. The gates as we speak now, is not fully operational. No, they are installing in phases. So now it's not full operational. So billing or crediting on the lab system itself is a challenge now. But in the past, they used to do that. The only challenge I realized that since I became head of clinical, I realized that many of the clinicians are not aware of the existing platform for some of these. So we'll be on the ward and the person doesn't have money. I mean, I always tell them if the person comes as an emergency, it's not money you are asking for first. You are admitting the patient will be billed. So only thing that for the lab, some of these things, I mean, what's the name of the platform? Games. When the games is fully operational, I can be. Of course, then it also comes back to the fact that not all the labs are around here. Some of them is actually a partnership with some approved private institutions. So they will take the sample here. The client does not know, but it is taken out because of an agreement that we have. So if the lab is one, the test is one that can be provided here, run here, not a problem. When the games even can be operational. But if they have to take a sample, say, in lab, then that one cannot work. But at least it's better we start and build upon this. Thank you.
Thank you all very much for the contributions. Last one.
So I want to make mention of something because of what Dr. Mrs. mentioned about some information going with the links, which I feel is critical when it comes to our care. And even because I remember at the time I wasn't in this facility, but I had a patient came around, was given a medication just around that moment, names went away. The patient came back, the doctor wanted to remember the medication he gave to the patient, couldn't remember, the patient couldn't remember. How do you continue care? I know this might not be the people who, the policy makers. So I know Regis, I think I've heard Regis planning on backup options in terms of keeping our data. So we seriously have to look at some of these things, and I don't know if they can be mentioned in the corridors of power to see. And yesterday we were talking a lot about data. Now when people come and want to do your research, we already lost data when we were bringing links. We now lost data when they brought games. So when you want to do a periodic study for 10 years, why are you getting the data for? You just have a year. And when you are structuring some of these electronic medical platforms, some of the engagement, because a checkbox, something like we can do a checkbox where in case somebody has antimicrobial resistance, there's a select option. It makes it easy to retrieve data. But when the doctor has to enter it as part of notes, anytime you have to retrieve that data, we can't go opening the folder by folder to check the people who have those resistance. So some of those engagements will help us to communicate the specification, user experience that will help us tease out the data effectively. Yes.
This session. I can see we are busy with hands and pens, so well done to everyone. I go. We go to this too.
Oh, we forgotten the clap, because we are So I will give us 35 minutes to finish our questions for the next one.
Hello, good morning. My name is Omoina, and then I'll do something on there. So it's a continuation of study we started yesterday. So I'll just rush through as quickly as possible, because I'm sure we know everything already. So, just brief, the relevance was spoken about extensively yesterday. We'll look at class shortly, and then we'll look at some epidemiology. So then, so the people here will determine how quickly we'll go through everything. Because most of them are things that not everybody needs, and we don't need necessarily to commence AMS activities. I mean, when we saw the institution, the committee formation and all, it looks cumbersome. Just a comment out to that. It looks cumbersome, but usually we can start from wherever we are, with whatever we have. We don't need the full set to start some of these things. So, I mean, we'll see some of those things going forward. So, yesterday we agreed that we need reliable data to make informed decisions. And then we need standardized data that we can compare, and then also we can track and see whether we're making progress or not. I mean, the reason for the surveillance, just like yesterday it was mentioned, post-market surveillance, pharmacovigilance, there are a few things that we pick in the practice. So we'll start AMS committees, we'll start ASBs, but then we'll need certain indicators to follow to know whether we're making progress or not. The fun part is sometimes, even after interventions, it creates a big problem for you that you have to address. Even the interpersonal ones that were discussed this morning. So some of these things happen. So we want to do that because we want to have standardized data. We are able to project doing procurement and all those things come from these things. Yesterday I mentioned the policies. This is just to compare the two. As we mentioned, as the first action plan had 5 objectives. Now there are 6. Surveillance falls under objective 2. I mean, it's still inside the stranded surveillance and research. That was 2015. Then in this year, the updates, surveillance systems and lab networks are still mentioned. I think it emphasizes the relevance of surveillance, and then you can't have AMS without surveillance, essentially. Yeah. So it's not so much work for us to do at facility level. Most of them goes to national level. Now, discussion about the data loss due to limbs or claims. Sometimes some of these things get to help us. Some facilities they upload data to WUNET on glass. So I mean that might have saved that problem. Because now that you have lost data from the lab from limbs, and to get a proper antiviral, you are looking at collecting data from about 12 months. So it means that you're unlikely to have quality data for your antiviral until after 12 months. So it doesn't look like it's something that you can do as soon as possible. Also, a few years ago, our facility had collected several data over a period. When we started AMS, and then we started interacting with other stakeholders, then we realized that it wasn't standard enough. So it wasn't what was supposed to be. So we had to go back and do a training on antiviral with them. That was the LST. Liverpool School of Government to see that so we can have quality antivirals. But the idea is to have data at facility level. But yesterday we agreed that AMR is highly variable. So the dynamics in rich hospital area where you will be different from Koforidua or Kumasi, the UK, the US. So it helps national when you have data. And at a regional level, that seems they define for us the objectives as how to do these things. Then dedicated and lab capacity. Surveillance rests on lab. That's the beauty about the AMR problem. You can't say it's a doctor's problem, it's a pharmacist's problem, it's a diagnostic problem. It's across everybody. So that nobody should be overly defensive. When we find a problem somewhere, we'll address it. And in our subsequent presentation, we see where the indicator measurements come in. So, the lab is, now there's AI also to help us with some of these things to better manage the lab capacity. So concerns as to how soon cultures will be ready and how all those things happen. There are some facilities that do not have microbiome. For instance, outside here is at the Raka Polyclinic, they don't have a microbiology lab. I mean, they were getting it as of last year, but before that, they are liaised with the private facility to get. So they're also trying with the small resources that they had to help in the AMS issue. So glass. So a lot of things happened in 2015. That's a 68th assembly. While Ghana was preparing for elections the next year, the WHO was busy trying to solve the airborne problem. So it's separated in about 3 models: routine data surveillance, focus surveillance, and studies and service. Routine is AMU that we spoke about, or AMCs. You monitor consumption or antibiotic use all the time. That enters routine. But sometimes you can focus somewhere if you have a problem. So let's say the lab notices that now E. coli culture is resistant to Cipro, or to Cipro maybe. We can decide if they want to focus on it. That's the picture about Dtc also. They can focus on these things. That's where research comes in. So that they feel that they've realized that there's high trend somewhere, there's some resistance somewhere, then they focus and then they do the work on. So aside the routine that you're always updating, that they focus on, then there are surveys and studies. An example is the GBPS I will look at later, the Global Prevalence Survey. So that can pick up snapshots or pick up trends in antimicrobial prescribing habits or general surveillance. So the aim for GLASS is a global AML use surveillance systems. I'll be saying GLASS a lot. There are other ones. There's an farming and news. Yesterday I spoke about in talking about the action plan. We learned or we remember that there's more focus on One Health. So right now all those parts are involved: the FAO, the UNDP, and then the WOH. So that's food and agric, environmental programs, and then the animal something there, all under the WHO. So speaking to the aim fund, that was a food and agric. We don't do that as hospital. Animals, we don't do that. We don't look at several data for those things. So our focus will be on glass, so a lot of glass. So the aim is to provide a common standards methodology for measuring and reporting national consumption. So standardization, so that we can compare. Because if we say we don't want to work in silos, beyond the DTC level, now there's a facility level. So we can be able to benchmark and see where the problems are. So it enables monitoring over time. Comparison between countries I mentioned, and then global and regional reporting. The objective is to integrate into the package of tools supporting national action plans to provide quantities. So when I spoke about standardization and then about we're going to project for programs, so that if there are malaria programs, they're going to need data from here to project to see how much they are getting and all those things like value chain or supply chain. Offer a common method. If the method is standard, the results usually will be standard and we can compare properly. Then that becomes reliable because you can reproduce and then we can track. Then feed into global consumption data as part of GLASS. Enable comparison with the animal and agric. Yesterday we agreed that all of us every day have antibiotics from the food we eat. So they are going to be as involved as much as possible. It is relevant for stewardship. When we were discussing about the specific guidelines, we agreed that we needed medications available with their surveillance data to get a guideline. Because the quality of the guideline is also falls on whether the medications are accessible or available. There's no point designing a guideline when you can't find the medication. So in Ghana, we agree that we're going to use when we have pneumonia, we want to use an antibiotic that is not available, then it becomes obsolete. Because you'd have done a document that will be useless because nobody can go by the documents that you have done. So available medications are all there. So when you feed to GLASS, then it also projects availability. I mean, you're able to see that, okay, they consumed a lot of Cipro, so those medications are indeed available. I don't think every facility line is solid. So if it's going to be your first line, then unless that is the only thing you have that is susceptible to that kind of organism, but otherwise you want to focus on what's available. So I spoke about this in the beginning, the national regional architecture. So we see a lot of well, I mentioned this because our lab experts a lot, so they can relate better. So even in pharmacy or other kid, you might not really relate to us. Because we are encouraging a multidisciplinary team, we need to capture some of these things. Yeah. So data is collected across the country, there's parallel comparisons. Because it is a global problem, however, it is best managed from ground. I mean, what we're saying essentially is that whatever guidelines are proposed should be specific to the facility. That's how you can carry it. So I'm saying that an antiviral from Manchester Trust Hospital, whatever, might be useless inside there. Whatever then, who knows? Their E. coli will still fall to some of the basic antibiotics or different sets of antibiotics. And our E. coli is different. So that's what I'm saying. So the setup or the structural governance we spoke about, the objectives, the data sources, they identify for us where to get data from. The SDG, for instance, there's a standard guideline that we're using in Ghana. However, data will not be collected from, say, Adabaka Polyclinic because in the time they didn't have a microbiology lab. But it's collected all across, and then they will make further decisions for everybody. That's what happens in the setup. The collection process, the validation process, and analysis. Scale up is as an ability comes to funding situations. I mean, even DTC has a sustainability plan, whereby it's funded. The same thing will happen to EMS. Unless you have some projects, just like now, Ghana Health Service Airport is who is handling this one. But the idea is that beyond this, I don't think the plan is to have this TOT maybe, and then go back in 6 months. They will call an answer like, oh, we didn't do because you didn't come back again. So I mean, that's will always be in the plan. Now we'll start with the AMU. That speaks to the medication that is given to the patient usually at the patient level. It's just for consumption. So yeah, so it's patient level data. However, that one we're able to capture. So if you do prescription audits at the facility, if you capture a lot of data. And we were doing that at the end. It was a simple form of it. You want to see what antibiotic was prescribed for what condition. The RUM, let me address this now. In the beginning, we're thinking, I shouldn't say we're thinking, but we're talking about RUM. It's quite different from what this one is. Because that time it's different. It checks injection use at the OPD, checks antibiotics at the OPD, generic prescribing from the EM and all those things. That's quite different. But at that level, we're able to see some of these things, sex identification. When we get to consumption, it's different. They are not, actually, they are not relevant in that aspect anyway. We see symptoms, diagnosis, and all those things. So this one can help with decisions at the facility level, clinical practice. So DTC can make based on this one. I don't know if you follow. So it's how much medications were given to the patient from pharmacy, like how much we're giving. Let's go to consumption. That one is not at the patient level, although data from there is needed. I mean, the estimate, I'm looking for English, I'm coming. I'm looking for English. So at this level, so okay, we'll pick data like consumption from say wholesalers, from programs, from facilities. It wouldn't include at the patient level. And this is better to work with because it's standardized. We see in the calculations going forward. If so consumption is not from use. Use is only at dispensing level. But this one is at a different level. What our stores will give us will be consumption data. What's our tally cards and all those ones. That is quite different from the use. Now there's a system we use in these things. There's the ATC and the DDD. This is the anatomical therapeutic chemical classification. A boss many of us are 5 levels, so the medications are coded. So when you do certain audits, it will come in some of those codes. It won't come as a medication itself. It helps us going forward. I wanted to mention because we want to have a look at it. We won't need it for most of us, but this is what we use. First level, anatomical level. There are some other 14 groups I'll show you going forward. Then level 2 is pharmacological therapeutic subgroups. So antibacterials, antifungals, and all. Then they are coded. JCJ, J01, and all. We're focused on antibiotics. So I want only the J's. Let me show you here. So that's the anti-infectives. So for that, other ones, elementary tracts medications, cardiovascular medications, other codes, but our focus will be on the J. I'm only mentioning this because when you do a PPS, you see some of these things. That's how the medications are coded. So we won't bore ourselves with them. This one. Also this one. So this one, where is also fun. So the DD system that's a defined daily dosing. Defined daily dose. Most of the pharmacists will leave some of these things. So because pharmacists say they are constitutional medications, we leave some of these things to them to worry about. But that's the assumed average maintenance dose per day for a medicine for its indicated dose in adults. Right. It's an assumed figure. There's a whole list for this one. It is the figure is given to us by the WHO. They have a statistical methodology committee, collaboration center. They are the ones who assign these doses. So you see amoxicillin maybe 2 grams. That is the assumed daily dosing for that medication. Then number of DVDs. So I left out calculations. No, sorry. So this is consumption data, not use data. I spoke about AMCs being more standard than the AMUs. What it means is that, and then we can compare. And also, if you have to compare between medications, so if I want to compare these for amoxicillin and ceftriaxone, for instance, I have to use all this calculation. I don't know if I am convincing or confusing, but stay with me. So, also DID, that's a DID per 1,000 inhabitants per day. Those are the standard estimates that we'll be using. Oh, what's that? I don't know if I should. Let me see. So if we were calculating, for instance, if we're going to calculate, we're going to see how many were used in that day, then we divide by DDD. So for instance, if an exact example would be for AME, for use, you can calculate and see that today, for instance, or if a prescription is amoxicillin 500 milligrams 3 times a day, then we know that we have dispensed 1.5 grams of amoxicillin to that patient. I mean, if it's 1 day, I don't know if you follow. Right, I'm able to know number of capsules we use for that particular one. But for the AMCs, it's different. It doesn't give us, it won't be 1.5 grams. Would have been calculated using DDs. So you see things like maybe 10 DDs or maybe. So if in that one, for instance, that would be 1.5 divided by, say, so let me use one that to make it easy. If we used 500 milligrams 4 times a day of, say, amoxicillin for that patient, we're calculating DDs. If the WHO one is 2 grams, that would be 2 grams over 2 grams. That would be 1 DDD. I don't know if you follow. Right. We'll use that one later to calculate. So that's the total grams used divided by the DD value. That's number 3 over there. Would have given us the value. Now for reporting metrics, there's the DID. That is the DDD per 1,000 inhabitants per day. So if our DDD was 2 grams, if our DDD was 10, we would have divided it by 1,000 and divided it by 365 to make the DID. On you follow. Are you with me? Hello? There's not so much English inside there, but I'm trying to speak.
When you meet the farmers, you teach them.
Oh, fair. I agree. So I'll skip it.
Yes.
Okay, so let me see this. I spoke about the value chain of medicines, where there was a procurement, distribution. Usually, the data is best close to the patient as well as possible, because there could be overlaps. I mean, from procurement to distribution. If medications were being moved across, it was issued to pharmacy OPD, then I issued to, instead of pharmacy ward getting it from stores, they would have got from me. So there are going to be overlaps in the use. So the process you add to the patients are better for the calculations. Later, when we talk about the collection, validation, submission to class, and then they'll need to check and publish, and then the dissemination. That's how it works easily. Well, there is an AMS team, national AMS team. Looks like we need to put more work into the AMC teams. That way, it would have been easy for us to relate on these things. Clearly, we need to adopt the system. We need to build capacity in the ATCDD system. Pharmacists will come and worry about those ones later. And we need to link this to stewardship. As part of surveillance, so that because you see, you can only track a surge in some medication use from the AMC calculation. Then you see that it's going too high. It means that there's too much use of something over here. Like I said, very easily, when you do audits, your assumptions will be flawed usually, because you can think that a pharmacy, we can think that they do a lot of IV capturation to non-stars from I see a lot of prescriptions. But when you do the audit, sometimes you see that maybe not. They have been using more of a tablet amoxicillin clavulanic acid 1 gram than that one. It's why we do some of these audits. So I'll stop here on this one. But whatever be the case, I know I've mentioned it to you. If I couldn't convince you, we'll read more on some of these things. We'll continue immediately with the GPS so that we can see on time. So for that one, I'll need us to be in 3 groups. And then we're hoping that there's a DTC member in every group, and possibly a pharmacist in every group. So we need to group into 3 and then we'll do that one.
Please, DTC members say number 1 to 3 so that can be in all the 3 groups. So number 1. What time is it? 3. 1. 2. 3. DTC member, yes. 3. 1. So, please, all ones. 2. So all ones will be here. Okay, Belinda, you are number 3. You are 2. Okay, 3. Okay, then Dr. Ada, you will be number 1. Are you 1? You are 1. And Mr. Saka will be 2. So please, all ones will be here, 2 in the middle, and 3 here. Then the rest of us, we will also number 1 to 3. Then then you join the.
One.
Dr. Banini, you are 2. Yes. 3. 1. 2. Dr. Banana, you are 2. 3. Dr. Ruby, 1. 2. 3. Okay. 1. Yeah, number 1, please. Please, so can we get to our sitting position? 1, 2, 3. Thank you. Please, let's move forward. Okay.
continue with the global quantifier setting. And then, that's this is the background. So, you will start your activities, as soon as you are ready to start. And then, monitoring them is very important part of the program. You can't do ASPs without having to monitor them. And this is a standardized tool that you can use to monitor them. When we go into details, you see how comprehensive it is. Because usually our focus is on, is there diagnosis, yes or no? So in that analysis, just like RUM checklists will give you, is the dose correct, yes or no? Yes. But this one is going to capture the fine details in your prescribing habits. Like in your prescribing and documentation a lot. You are going to start a lot of work on it. And then the not found part is the documentation. That's true. And if you don't document, you don't prove the work, unfortunately. So it's a lot of reports writing and all this, data analysis and all that. But I've seen that you have dedicated research institutions from yesterday's conversation. So I think it should help. So it's supposed to be a simple, freely available web. It is freely available. I don't know, the simple depends on you actually. It could be simple or not simple. And then it is we use it across the world, actually. And then you know the UK and the US have their own system. But across the world. And then we're able to benchmark the data across all. So there's a facility one. You can compare at your level. If you're a tertiary facility, primary facility, secondary, you can compare data across that level. You can compare your indicators across Ghana, Africa, and Europe. So you're going to see. So I'll show you one of the surveys you did sometime when you see. Also, so that those who assume that life is better, I'm not saying it's not better abroad. I'm just saying that those who assume that it's greener abroad, you'll be surprised that some of the data we collect, we do better in certain matrices than they do. It's very easy that, oh, because the UK has ABC, they do what. This will show us that sometimes we're better at certain areas. I'll still do this quickly. The aim is to monitor the risk of antimicrobial prescribing at the facility. That's one of the main aims. I spoke about benchmarking across hospitals in the region. Identify targets to improve quality of prescribing. So the beauty about this is also that when you're able to do this, you can identify what the problems are. So if you want to do, you have to do trainings. It's going to be continuous. That's the truth. One of the reasons would be the high attrition of staff. You train people today, then maybe they are house officers, they have to do rotation elsewhere, they leave the facility, new people come in. Or people are transferred, people will retire, and all those things. You see, you can't train yesterday and assume that they will know it. This will also show you the effect of the high attrition. Because when you have been trained people for some time, the weekends are off. Right? There's one, I don't know how many of you know it, but so when Lekma started backup prescribing, one of the interventions, then what backup is that when prescriber is unclear that it's a bacterial infection, they give you a post-dated prescription. Right? So it could be viral, but so I write a prescription, but it's a system thing, you have to all be involved in it. So today is the 26th June. So you write 29 June on the prescription. So when his pharmacy, you know that, oh, then he's saying that when you get worse, should you get worse, sorry, if you get worse, come for the prescription. If you don't, then you can continue with your life. And surprisingly, many people continue with their lives. So there was a case that the patient came to Regional Hospital. And the story was, at Lekma, they don't give antibiotics. Then there's a poor communication. That was not the situation. But, so that's happened. So some of the discrepancies and the fights are bound to happen. I want to manage the expectations so that when you start, you don't lose hope in the beginning. When you see the reports, it's cumbersome. It's a lot of colors, but when you sit down and you slow down, you're able to see that it's not as the report as it is. You're able to identify HAIs. Yesterday we mentioned some of those ones. That's the intervention-related problems. So because you left a cannula in someone's for so long, got infected, it's your fault, it's not their fault. The catheter and all those ones. You see, they say that the pathway to hell is paved by good intentions. So sometimes in our way to help people, we spoil a few things. That happens. So it's also there. To assess effectiveness of your interventions, you see in your indicators. So when you see, are they prescribers guideline compliance? Yes or no. When you do a baseline, it could be low, that's so low. But when you start activities, whatever trainings you are doing, what runs and all those things, and then you do again, you see this still low, it's still high. So you're able to identify, say that, oh, what we're doing is making progress. Otherwise, then, we wouldn't know. It helps you design the interventions also. You are going to be making changes to routine things in the facility. That is why you need a leadership commitment. So when AMS makes a decision, okay, so in a facility, we won't supply, we want to do pre-authorization, for instance, as an example. So a certain level of prescribers can prescribe vancomycin or meropen, as an example. You see, if it's not what's done over there will be kickback, or what are you saying? I'm a second year house officer, I say I cannot do it. And maybe that's the hospital's policy from the AMS. It has to go to the Dtc, they are going to go to management. But the moment the director says that in this facility, is what we do, I don't think one person can say that. Give it to me, pharmacy by force. Because there's an instrument from leadership that says it's less than that. So some of your decisions will come from some of these audits. The benefits are supposed to be easy to use, and it's real time. It's real time and it's consistent. You see, when you go over, you see that you can be able to track. It's standardized, so it is consistent. It improves healthcare quality. 2021, if I'm right, I think at regional level, so Lekma became a case study for something. Dtc, yes, at the and Adabraka, the meeting was Adabraka. And then their antibiotic use at OPD had dropped below 14%, above 14%. And then some of the reasons was because that time they had started AMS symptoms. Also backup prescribing. So that's an improvement in healthcare quality. Because people were doing, I've done some audits for other facilities, about like 70%. That's a lot. And let's bear in mind that yesterday we agreed that once there is use of antibiotics, there is resistance, whether rational or irrational. It's not about whether it was rational or not. Once there is use of antibiotics, there's certainly going to be a rise in AMR. In this audit, the forms you have, there are specific times you can do it. So there are 3 times in a year you can do it. We call it P1, P2, P3. So you see P1, it means that between January and April, that's P1, and May and August, September, and forget the years, I should have removed that time. Every year is the same, it doesn't change. So P1, it's a snapshot. It's just a, okay. Sorry, inclusion criteria. So this is for, there are two, you can see there are 2 forms. So there are 4 forms. 2 protocols, data collection forms. One says OPD, one says IPD, the inpatient. If you look at the forms now, the reason behind the rules. So one says ward patients, so that's ward. Then one says OPD. So this slide will be for the inpatient. I have wanted to put everything together. So at the inpatient, so let's pick the inpatient form first. The word form, yes, this one. So when you look at the word form, so which one? One patient form. So when we put everything together for you, when you pick one, the one that is like this, it has the word form and then the patient form. So the first one is the word form. Otherwise, also to make it easy for us, let me just run through. You see some going. I want to make more practical. I'll just run through and then we'll look at the forms. If that helps. Right. Okay. So usually we will take the data. You are going to form a GBPS committee, first of all. You have to have a pharmacist in all of those teams. So it's a team, not a committee, it's a team. You must have a pharmacist, you must have a lab expert, and then a prescriber. That's going to be the team because of what you'll be doing as going forward. Pharmacist, lab expert, and the prescriber. Those people must be part of the data collection. We call them auditors. They are going to go around to check, to fill the forms that we have. So every patient should be on active antibiotics. Active set means that the day you are checking, they should have been on antibiotics. Not a discharge patient. The day you are checking. But what happens is so usually by 8 a.m. it's assumed that maybe people that finish rounds and all those things, medications like that, administered. So they're the ones who qualify for. And you do it, you don't do weekends, you don't do holidays. For this, that's how it is. Usually in most service, when you like in most service, the weekend is a lot of it's a different story. I'm sure you want to focus on a different audit for weekends. But you can decide for yourself. That's the beauty of this. You can say do for weekdays and do for holidays. That's when you see that lots of trouble happens. I don't know how many specialists work on holidays, how many senior people come on holidays or weekends. So then there's some problem. So it doesn't paint a proper picture if you do holidays or weekends. So I advise you do Tuesday, Wednesday, Thursday. Because Friday in Ghana, people are usually. Right. Monday, they are still now trying to recover. So if you want to, I'm saying because this is it takes a snapshot of the, so you see, so that you don't go and take on a weekend where the bosses didn't come and then people did whatever and assume that tells the story for everyone and doesn't. So for the quality data, I want to do Tuesday, Wednesday, and Thursday. That feels like a better this thing. So if they are not on antibiotics at by that time, you don't include them in the if people on the ward is charged, they are not included in the survey. Okay, I spoke about the team of people that go into this. So we continue. You are going to designate someone as an admin for GBPS or the coordinator for GBPS. They are going to so whatever paper forms, they are going to now upload the data on paper forms onto the Word forms. So someone will ask whether is it not easier to upload directly onto someone's sincerely. That when you realize that you are better off on the paper forms. It's not on the paper forms than going directly onto the Word the platform. So we'll do the registration for you, but the beauty is that you control everything. You have access, you have ownership of the data. Whenever anybody needs it, they'll write to you before you engage. So although you'll be uploading onto a web like an open database, it's still your data and only you be able to access it. I spoke about ownership. So they coordinate, the University of Management, they coordinate. And periodically there are some conferences and seminars. People write on some of these ones, they publish on these ones, and then they do certain presentations. But they analyze the data. So when you collect it, if you've ever done the prescription audit, I remember before the OPD PPS, we were doing the audit. It was not fun thing for me at all. Because it means I have to come back and analyze all these things. If you have a research, it helps. But what we didn't have, I had to sit down. I think I lost a lot of weight that time. I was tall, fat, and fair when I started. You are not there. So that happens. So that's so I'll do the registration for you. That's to register, and then we upload on the platform. There are departments. When you look at the word forms, you see departments. But to start, they are going to be divided into 3 activities: medical, surgical, and ICU. So when you see activity, it will mean medical, surgical, or intensive care. That's what it will mean. So the words that you have OBGY, surgical or medical. I mean, you have a medical ward. How you want to name it, that's the beauty. You can name it however you want to name it, even on the form. But once it will be grouped in the activity, it's a medical, surgical, or ICU. Okay, so this is the word form that you have over there. The date, the person doing the audit, the hospital name and the ward name. So there you see adults and pediatric. There's no pointer today. So adults and so you see AMW will be adults medical ward. If you saw ASW, that will be adult surgical ward. So yeah, adults medical ward, adult surgical ward, right? And then the pediatric wards. So you see them. If there's an ICU, the ICUs are here. So your NICU, your PICU, and all those people who go under these ones. So in the morning, when you are ready to go for the, your team is going, and you pick. So what happens is that, what we do is that every room gets one word form. I don't know how many, at medical or internal medicine, how many rooms you have in internal medicine? I'm only saying like to say that one door leads into that's one for it. So at least like 4. So you have 4, let's say you have 4 not beds. The room. Yes, the room. If you have 20, that would be, if it is adult medical ward, it becomes adult medical ward 1, adult medical ward 2. So when you're entering, if this was a ward, if you use one word form for that room, so you go to the other medical ward, but use a different form for it. And if you follow, yeah, right. So that happens. So you realize that you are going to have a number of word forms. There will be a temptation to work quickly. You see, because I've seen it, usually I can tell you before you start, and so you can learn from common mistakes. To finish quickly, so you see, because there are three of us, I'm the pharmacist, lab expert doctor. So we want to give it, usually there are errors. There are lots of errors because when you pick one case and you get a targeted treatment, you need a lab expert to show you. So there's an appendix, but they understand it better. To show you whether this is in this category or not, whether there's some type. We'll get there, you see it. Then the doctor and the pharmacist will tell you whether, oh, this is kind of compliance per the treatment that you have seen. That is why you need everyone to be involved. Right? If you don't do it properly, whoever lose the data will suffer. Like I said, I used to be tall, fair, and fat. I suffered because you have to go and validate all those ones before you upload. If you upload inaccurate data, it will give you that feedback. Right? And you see, because you're going to do disseminations after doing these things, if the doctors really feel that, because we speak a lot to prescribers, really feel that, so it's not a true reflection, it's very difficult to define. That's why you need the paper forms, so that even after 10 years, you can go back to paper forms. Or when you have problems in the data entry on the web platform, you can then go over and fix some of those ones. So that's what the word form will look like. So the dates, and also it's a point prevalence survey. So it is 1 day in 1 word. If we're doing medical work today, it's only today we're doing medical work. That is inside that room, right? So that if we did medical ward 1 today and we couldn't go to ward 2, we'll do ward 2 tomorrow. We won't start and say, let's do half and then continue. Your data will be valid. It's point equivalent 7, so one snapshot. What we are following. So if we're doing today, we'll finish this one today. So it means that we don't finish this and we don't stop. So if you're at medical ward, you can. That's why there's a date on each department form. So there's going to be a date on it, so it helps. If there are 20 beds inside here and we enter here today, we finish 20 beds. If we think that we can't finish ward 2, the 20 beds, we don't do that. Because the patients can move. So then it disturbs your data. The quality of the data, speaks to your integrity sometimes. Right? People massage things up and down, but then because you want to see a true picture of the problem so that you can fix it. Also because we agree that we are involved in the AMR problem. So if we're able to fix it, then we need to do these things properly. Okay. So I spoke about activity, right? Medical surgical ICU. I spoke about the survey times. Okay, on the same word form, the unit form, you see when you come down here. Yeah. So when you go inside there, you are going to state the number of beds in the room, empty or not. So you give me it's a 20-bed ward. Your denominator will be the 20. Then those who are on active antibiotics will go into your numerator. The admitted patients, so there are 20 beds inside there, and then we come 12 are occupied. So it means that the numerator 20, number of admitted patients 12. That is how you can measure prevalence. If you miss that data, it will express your results. Right? So if we came in here and we saw 12 patients, but 8 are on antibiotics, we can calculate prevalence. Right? So number of beds and the number of actual beds in the room. Number of admitted patients. So the medical ward, someone might come with a CVA, might come with a hypertensive emergency, might come with a DKA. Those people, if they're not on antibiotics, they're not involved. So in our inclusion criteria, anybody on active antibiotics. So you're not going to be auditing someone who is doing amlodipine, and that's not your business. Right, it's only for those who are on antibiotics. Over here now, it will be only on systemic antibiotics. I mean, like orals and rectal, orals, rectal, and then you cover topicals. If you went to say you focus on topicals, you only focus on what you're taking. If we had finished the DEDs, we would have seen how those ones are. We don't capture those ones. It's difficult to capture those ones. We don't see those ones. Are we still moving? I hope the wards are segregated. Medical, surgical, they're not mixed. I don't know for the OB/GYN, but even if they were, I understand. There's a room for mixing. I mean, you can see if it's a mixed ward, yes or no.
You see, we have a very peculiar system. Even though they are separate, we run a functional bed system. So sometimes on a medical ward, we have surgical patients there.
Oh.
Because if there's no bed and the bed available, and but the name of the ward is medical ward. But the patients there might not.
So you choose mix to make your life easy. Just choose mix. So you see that on one word form, because you can have mix, but the problem is going to be the number of beds. Because since you haven't designated a number of beds for surgical in that particular room, it becomes challenging. So what you can do in that one is that if you have 2 surgical cases, let your number of beds over them 2. So we have 20 beds inside there. This medical ward. However, we have 2 surgical cases in medical ward, right? So assign 2 to surgical and assign 18 to medical, right? Because for surgical, you're going to have usually 100% prevalence. Because there's going to be prophylaxis. Post-op, so you're going to have a lot of antibiotics there. Yeah. So if it's mixed, just need to mix and then indicate on those forms. I hope we will follow that. So I've spoken about the forms. Okay, so I think similar to what you have. What you have is the latest form. That's the latest form. So there might be some small change, but it's still around this. So if it was mixed, you indicate mixed, and then you do the allocations. So I was saying that if there's no allocated for surgical and medical room, just total base, you write 2, then write 18 here, then you can get to, and be able to work it on from there. Yeah. So we have a ward form. And this is a patient form. There's a one, and then there's a patient form. On the patient form, what you have there should be similar to this. You have the ward name. So the ward name you assign on the ward form is what you assign here. The ward name you assign. So if on the first form, that ward was AMW1, over here it will be AMW1. Right. If for so it means that when you have one word form, you have a number of patient forms attached. So one word form will go with the number of patient forms. Right. Then the activity, I said medical, surgical, ICU. Then the patient identify number. So usually you can use the folder numbers for that time. You see, like I said, the paper forms are what you can follow if we have challenges. Today, LIMS is gone and we lost data. If we were writing, like in my days back before all of you were born. we would have been able to refer, but right now life is easier and better, so we use some of these ones. But the limitation with that is that when there's no light and there's no. So this survey number will be generated by the system itself. That's also to track. So the beauty is that I can go back and track on the system. So the identification number, that's a tool, is for you. It's the patient ID, whatever the KIMS number is. And then that's the transaction ID for that entry you did. You can go back and edit an entry. When you do, it will change the survey number for you. So if we have problems and I need to send an email to them, I'm able to identify what happens if I needed support, and then be able to fix some of these problems. Now, for the patient age, if they are more than 2 years, you rise the age. So 4, 5, 6. If they are less than 2 years, it's in months. So 1 month, 23 months. If it's days, and you rise in the days. The current weight in kilograms. This is where most of the problem is. So finally, most facilities will record the weight. I don't know why, but it looks like it's a culture. So that's we see that a lot. If there are units and you have the gestational age and the weight, you include the words. That's if there were units. Now male, female, or unknown, usually we move from this part of the world that they are male or female. So that's what we're saying. We're still with me. Now the second part of the form is the treatment based on biomarkers. So which biomarkers? So that will not include that will be from cultures. It will include your WBC count or your CRPs. That's different. So when we're talking about empirical treatment, we see a lot of no in that one. So no, it wasn't. So if yes, if yes, then which of them it was or other? Hey, sorry, I'm missing it. So when you do the MBC, right, what you'll be looking out for, if your treatment is based on WBC, you record it inside there. Are you with me? So yes, we did a full black one before we started treatment. So what marker did we use? We did the white blood cell count. What sample did we use? Is it blood? Is it whatever? That will come in the form if cultures were done, right? Whether that was blood or not. Now the value that you're making a decision on, that will be the value in the unit over here. Have I confused you? Whatever marker we're using to make a decision. So that we've gone to the ward. Now patient B is on antibiotics. Then we check in the system, in the folder. Why is he on antibiotics? As a diagnosis, as a diagnosis, they did a full blood count. The WBC count was high. That's the reason for initiating treatment, right? So would have indicated the WBC over here. Now, what sample was taken was blood. So blood goes inside there. What value was recorded, and then we use that. But very easily, you are not going to engage the prescribers on the wall. You're just going to pick what you see over there. So it's not going to be why are you doing ABC. You go inside and then you pick the whatever you see that's documented. So if it's not documented, it means that it wasn't done. That's what it means later, right? So when the full blood count was done, so we record those values, the value and the unit. Then we're cultures sent to the lab. This speaks to practice. It speaks to habits, right? So the point is that we want to encourage prescribers, maybe over the average, to request for cultures. Whether they're done or not is not us, but then it speaks to our habits if we're requesting them. So if yes, you indicate which sample was taken. Was it blood? Was it urine? Was it stool? Was it lymph swab? You indicate inside here. Right. Now the next one, when you go into the treatment, there's antimicrobial name, the generic names. That's what we indicate. So was it metronidazole? Was it meropenem? Whatever it was, we indicate all those ones inside there. So we've been talking about antimicrobials. That means that yesterday we included everything else. We included antifungals, antiparasitics, antibacterials, and also then whatever your focus is, you can capture over there. So over here there's metronidazole, for instance, or meropenem. The start date of that antibiotic, can you see that? Over here, start date is antibiotic. So you indicate the date over there. So the point is that we'll go into day 226, but when we went in, the patient has been on antibiotic 3 days prior, 1 week prior, we indicate the start date of the antibiotic. Right, so we went there, it's been 2 days ago. If we go there and then we realize that he was on metro and meropenem. Meropenem was stopped yesterday. We don't add meropenem. It's only on active antibiotics. So we'll add meropenem to that to the audit form. But it started on IV ceftriaxone, then they switched. So once they've stopped IV ceftriaxone, we don't do that. But you find concomitant use like this form showing. You go, the patient is on amoxil and metro. The patient you record all those ones. So for metronidazole, for instance, the start date is there. And you see that sometimes it's different start dates. So for KEF, they were doing ceftriaxone, they started 21st June. For metro tablet, they could have started yesterday, 25th June. You record all those ones. Then when you look here, the left side of this one, over here is a single unit dose. So what dose of metro was written? 400, 200, 10,000, whatever you record over here. What units was it prescribed in milligrams? So if you go and research it, you write ceftriaxone 1,000 and the unit will be grams. It will be milligrams. If you go and see 1 and it is grams. So you decide how the system allows you to do that, so to standardize the letter. Then the doses per day, is it 3 times a day, is it 4 times a day? You indicate it there. You don't need to write BD or CDS or body, you can just write 3. The system was in the input on the platform, so on the web page, so that it will still remove all those things. Then was it parenteral, was it oral, was it rectal, was it inhaled? Whichever mode of route of administration that antibiotic was, you indicate it over here. You see where we are. So over here is that's oral. It was an injection, that would be P. Over there. Now was the diagnosis stated? So the diagnosis will move to Appendix 2. On that same, when you saw the word forms, there are appendices to that were attached. So Appendix 2. This is Appendix 2. This one. There are 2. Also this one. So we won't be writing pneumonia or cellulitis or pyelonephritis, otitis media. This one. I would be. We won't be writing those ones. We'll write otitis media and pneumonia. There are codes for all those ones. So when you pick the diagnosis form, the folder, then you find the code on this one. I would be.
clinician, pharmacist, and the lab. So we need you to constitute that team or the teams, and then we'll come and have a training for them. But if you are going through this, it might take us, but at least you've gotten a fair idea of how it will go.
Absolutely.
So,
Periods within which you should put this on. So you start from January to November. So is it within that period you should have done it? How many patients are you supposed to do for, or every patient will have to run between that period?
Okay, so then it allows you periods. So it's open for that one. So if you miss P1, you can do P2 or P3. But if you have poison data at that time, you should go into P1. So what I'm saying is that the most service you can do in a year is 3. You can decide to do less than 3, 1, 2, or 3. That's what it was. So it's every. So to make it easy, I think when you start small, it helps some of these things. So you can decide which words you want to handle. You can decide that's okay, you want to do this one. At least you get a fair idea what you're doing. So that you know, when you start small and then you make progress, I'm even encouraging to pick up 5 and look at it as a bigger picture. So most of the discussion I'm having today is that we're looking at the bigger picture. I'm trying to find English, but there's not very much English inside this one. So no, it's not every day, it's once. It's once. So if you can dedicate, when I said Tuesday, Wednesday, Thursday, I meant that the best days to get quality data. Weekend, everybody is weekend then. Monday and Friday are two weekend. And no holidays also. So I was saying that you can't finish in one day. As a truth. Looking at you, I don't think you can even finish in 1 week. So it depends how many teams you have, how many pharmacists you have available, how many lab experts you have. In the morning, we're talking about having allocated times for AMS. I pray grace for you. Sincerely, I don't know if you can have. I don't know where you can have. So with this, we went around a bit sometime. In some parts of the UK, they have designated AMS teams. I was like, good for you. But you see, I'll have to go on ward rounds, I have to dispense, I have to do whatever, and come and do this one. So, you need a lot of, I don't know, beyond motivation, you need a lot of passion also. Yes, to have to do some of these things. That's the truth. Yes, that's it.
Thank you very much. So, you made a statement that we own the data. Then I am thinking, you said that it's housed by a particular university, they do the analysis. So, how can one survive ownership when the data sit with a third party and that they will do the analysis? Because when I look at this, once you go into it, this is a high level research. Is this something that ethics come in? Because if for something that is WHO, some organized global body collecting, that's a different thing. But when a university, which is a research institution, a third party, so far as where I sit is concerned, I was like, this is quite weak. So if you can explain a bit. Then other bit I think I can be simple because I realized that you need somebody to walk you along because it's quite heavy. You probably need somebody dedicated, one of your team members who are dedicated to reach up on. So we are very conversant, but I think that could be that again.
He has asked a question that I was discussing with Madam. So on top of that, if the university is doing the analysis, is it going to go for a fee? If you yourself you just mentioned it about names. So we don't want a situation where we have generated data, it has got to somebody's platform, and then you want to come back for it, and your own data you are not having access. He has talked about it already. But if I should have access, or you are doing the analysis for me, am I going to pay for the analysis or is for free?
access to use data. And then they write to you. So if you want to use the data, well, if someone else, let's say, so Ghana Health Services, who is coordinating this for you, right? They want to use their data. So they write to you. As I said, when I create the profile for you, you control it, right? So nobody can back to the represent to you. And then you tell me, you can use my data. Oh no, you can use my data. So you get excluded from their research. It is their protocol. So they are going to analyze it. And I'm glad they are the ones analyzing it because I was able to analyze it. I'm also saying because before, so this is IPD. You saw there's another one that says OPD. Before this one came in, we're using the OPD one. So I had an Excel sheet I was working on. I was canvassing. At the point, I sent a note to you and said, I need help with some of the analysis somewhere. They're like, oh, they had a research guide for them. We didn't have it at the time. Right. So it was canvassing. So I was glad when I didn't have to report on OPD prescribing audits because this one came in. When we go for it, I'll show you. I have two results I'm going to show to you just to. The analysis is almost instant. Might take maybe 15 minutes, but then when you complete and they send you the thing immediately. You don't have to pay for it. Actually, you don't pay for the feedback report. I'll show you a sample feedback report we did last year on the facilities. So you see. No, it's their protocol. They designed the protocol. No, they have designed the entire protocol. This is not.
They have partnership between the Ghana which you know.
No, it's open.
So the point is that for data management, when I own the data, when you give me the data is mine. Even though on paper you are saying you own the data. Individual hospitals have transported the data or transmitted the data to your server. And now all the data in Ghana is sitting on your server. You have access. Not until you get the data to your end, you won't be able to analyze it. So the data has been transmitted to your server, which you have it. So whether I am owner of the data or not, you practically have the data. Before you can access and analyze the data. And if you have the data, you have everything. That is my concept. And there's no partnership, there's no data agreement signed, and nothing like that. Somebody sees somewhere, and the person is making money, and then we are generating money, we are not getting it.
This one, beyond our salary. Let's make progress. You understand? This one is another discussion, so let's make progress.
Yeah, I think, I don't know. I see the concern. Unfortunately, I think it's not. My point is, you have ascribed to use their protocol. So you have agreed to give them data. I think it removes that concern. Because fortunately, the results come to you almost immediately. You get the result back. And if anybody wants to use that result, they get to get it. So unless if you have those concerns, then you don't ascribe to use it.
So I think there are instances where the Ghana Health Service partner with other people in these same circumstances. But then what happens is that we adopt or adapt the tool. And sometimes even work is in a way to suit our context. So is there anything like that in this instance? Because it looks like so long as we have accepted to use the tool, the data must go to them. Because if we are adapting or adopting, we could also have our own systems where the data will be reserved for us.
Thank you for all these concerns. So this training has been helpful so that we know the concerns that are coming up. Just like he said, this is an open source resource that we can use or tool that we can use. And it's been helpful because those that are experienced in the past, they've been having a lot of challenges. So when this one came to make it easier, then the thing was why not? But then we have a steering committee at Ghana Health Service, and these concerns will be taken on board seriously, whether we are adapting and getting our own developed, or we are signing some agreements of data protection with them and all that. So thank you for the concerns raised. The steering committee will look into it.
Okay, I want us to wrap up as so when you look, there's also when you are going to have the forms, the protocols are also there. So you see certain, I don't know what the difference on, but we went to government schools, I don't know how you go about it. There's some small numbers in the documents, like that super space or blessing. So that refers to the appendix. Right, so you see over there. When you get to the type of education, is it healthcare part of the community part? It's things like CAI, HAI, and all those ones going forward. You get to understand it. Whether it's a medical prophylaxis, MP, or surgical prophylaxis, whether it's a 1 day or multiple day prophylaxis. So you see SP1, SP2, SP3. When you look at the appendix 3, I think. And that's 3. So that happens. Now listen, on your newer form, there's a breakdown of the guideline compliance. You see that's the difference that you see. Since you have a new form. So is a reason it goes, it indicates over there, maybe for cellulitis, hepatitis B, whatever there, was it there? If reason is there, it's yes. If it's not there, it's no. You're going to see a lot of no's. You have no business asking the prescribers. So quality of service speaks to documentation, or the quality of documentation. Sometimes they are not there. They are not recorded. When they are not recorded, it's like when pharmacists go around, so they administer medication, but nobody signed on the prescription. So was it given or not given? Well, we use pill count to remove all these discrepancies, so that you only go there to pick your data. You don't engage the prescriber. The only place you engage is when you see missed doses. And the reason was not received, and that's why they were missed. Otherwise, you don't ask. Whether they were not purchased, whether it's unknown, because you might get missed doses. When you come, there's some missed doses inside. You capture the number of missed doses. So, guideline compliance, yes or no. So, now they've written tablets, they've written oral amoxicillin. 500 milligrams 2 times a day for an indication is cellulitis. Is a guideline compliance or not? So yes or no? If it's not, you indicate no. If it says you indicate yes. So the guidelines you'll be using are either the STG, unless you adopt a specific guideline, or you can say okay, in our guidelines it is whatsoever. And so in that one, there's a conversation at MOH level. You can't just say at bridge you have designed, but there were some concerns. As an STG, and then you have designed your own based on your antiviral. You still have to come back to guideline service and come and say the reason you are doing that here. So, but once you have that, then you use that for the form. So guideline compliance, yes, no, none of that, no, any of those ones. Stop or review is a very important part also. Very easily, you see that they leave the prescription open. You don't know when it will end. The treatment. Valid reason, but you want to document it. At some facilities, we ask them to write maybe for 24 hours. Because I can speak for Legma at least. They don't supply injection antibiotics beyond 24 hours. To push, the idea is to force reviews. You don't want that blanket, patient has been on. Because we saw IVOS switch on the slides. IVOS switch, IV to oral switch. Yeah, we want to encourage that. Patient is fine and can be on the oral, so want to do that. You don't want to keep the line open for too long, because then you can introduce microbes into it. So that's where some of these things are. So over there, you are forced. So it doesn't matter whether you are some specialist from wherever it is, hospital structure. Because DTC, AMS said let's do that. DTC agreed, management agreed to it, so it's done. So even if you are practicing from calling when you come. When you write, it's applied 24 hours. We want to push you to review every client because they will change. They will get better, they will get worse, and all those things. So if you go there, then the prescription is IV Kevchars with 2 grams open. It means that there is no stop or review date. But if it is there, even if they write for 20 days, it's stop or review date. But that one, we don't speak to why it is 20 days. It is written over there. So we encourage prescribers to indicate it. you're not sure when it will end. You don't think that, but the concerns are sometimes your relatives are not there, so you want to buy the medication so that when they are not true, valid, no two ways about it. This speaks to the idea of AMS. If you police the prescribers, you miss the plot. You don't go and say why you prescribe, no, that's how you do it. You don't police them, you're not antibiotic police. I've seen people that are doing that. You miss it. I mean, you try to work with them because outside textbook, we have programs on the ground we're trying to manage. That's how AMS comes. To get behavior change. When she was, I'm like, okay, you must also consider employee leadership programs in your AMS committee. I mean, whether it can be whatever you want to use, because you need to find a way to approach the problem. So this comes in. When I said the lab was very relevant was over here. That's the other way. They don't even fight for it. They know what all those things are. MRSA, whatever, they're able to indicate for us. But you only get here if you do a culture. So it says here, treatments, empirical or targeted. I can assure you that maybe 90% will be empirical. Also because sometimes the culture would have been taken. But then, if the culture was requested on Wednesday, today's Friday, was requested yesterday, although it was requested, the current treatment you have is empirical. Because quantities haven't come yet, so it wasn't informed based on the culture. So this is what it looks like. I'll skip. So we've spoken about this. These are the appendices. We've seen them. So I would have done a live demonstration for you. I was going to do that, but I'm sure we'll skip it. So when next year, that's what the dashboard looks like. So the data you have, whatever would have come inside. That's all. So you see, all what you record on the paper forms, you come and input them over the start dates. When you make a mistake from here, you will not be able to even save the documents. So we'll bring a warning, the treatment type, that you see they're all pop-ups. So you'll be writing, you'll be choosing from the drop, so I mean drop down, drop down. I spoke about it in cross-sectional snapshots. So it speaks to what's happened over there that day, but when we're talking about it, it will make this look like, okay, that's what's happening. So the more PPSs you do, the better for you, because you can find the trends, you can speak to, if you use one, you can't say too much. But of course, one becomes a baseline, and then from there, you can add the trends. So, okay, this is old, but the concern you raised about, someone raised about, about when you do it, when we started, we realized that it didn't really speak to our practice 100% in Ghana. There was some challenges, but when we went on, we realized this will mean this, that will mean that. So in the beginning, it might not sit with what your structures are, but trust me, it fits in eventually. Like it works. It makes life rather easy for us. I think we've spoken about this essentially. Okay. Let me show you just so you see something right now. So this is what the feedback reports looks like. Let me use the other one. This is what the feedback reports looks like. Right? It's about 65 pages. So at that time, the number of, it's worldwide. I want us to see some very important indicators in there right now. So you see, it does the consumption first. After you're choosing amoxicillin over the facility, it does the use for you. The most important indicator, yes. So after we do all the things we collected, the things you can speak to from the thing is that, so in this hospital, 94% reason notes. So it means that some people were being given antibiotics without documented medications, right? So very easily, we assume it's 100%. Oh, they write all the time. I'm sure all of us assume that we do it. Every prescriber does it, but just like the peer review, I mean, and we see that we're not doing certain things, so similar. So about 94%. You see, we can benchmark. So across the country, it's 80.8%. So this facility is even about doing better than so if it was you'll be here. That's our hospital. Right. Reason is 94.7. In Ghana, it was 80.2. In Africa, it was 82.8. So even Ghana is below the continental average. You follow? Look at Europe. 77. So it means that the AMS committee, they will suffer more than those who are suffering here. But oh, doctor, write the indication. It's not written. No. Sorry. So I hope you get a picture. That's when you come to guideline compliance, they're very important because we are going to be heavily empirical. At the facility is 92.6. In the country is 88.8. It is 77.8 inside Africa. It is, I mean, so you can see going forward. So this is for medical. When it came to the stop or review date, it was 78 over here, 44. So this facility, well, that's like actually, you see, 44, 48, 42, over here is 44. So you appreciate the thing. And I was saying, so this is one time, this is last year Q2. I could show you other ones that over here it came to about 24%. Even after AMS programs are starting. So this one, you get to understand that, oh, we're doing right or not doing right. I mean, you get to see there's another one that's also very important. Almost there. Yes. So you see, the things I was saying are trying to update their work classification. Will you be mentioning later? So I won't say too much about it, but it was captured. It does that also for you. Whether you're prescribing, the targets have changed. This is last year. I told you the updated action plan. This has now gone to 70%. The access group, I'm sure we'll see that in the subsequent it's now 70. So last year it was 60. That's the target. It means that globally we want to consume 60% amongst the access group. So they did 68. So now 70. So it means that they would have fallen short if that maintains. So I mean, it looks cumbersome when you start describing this. It's easy, it's like send a text message and then you begin to enjoy it and then you see. So if we're going to do trainings, for instance, we can say, oh, at the medical ward or at wherever, at the OPD, you realize that you're not adhering to our work classification. That's the point to focus on that. Thank you. I'll skip the OPD. Thank you.
A bit technical, but very well done. Thank you very much. Please, we can turn ourselves there for return to activity. And stretch a little bit. Yeah, we are mindful that everybody will want to we are very mindful. hospital, what their plans are going forward, and then we'll wrap up.
Thank you.
The forms, let's keep all the forms with the Rabina. Hello?
Yeah.
Please, all the groups who have the forms, let's give them to a Rabina for safekeeping. When we move forward and we will need them then. Otherwise, we will.
Wanted to do extra work.
Extra work.
We are here to support you, so we will collaborate with you, give us a date to come and do training for the small team that will be conducting this survey.
Good afternoon to us all once again. So we are taking this last presentation and then we'll call it a day. The title of the presentation is on ensuring access to appropriate antimicrobials and other health products. Ensuring access. How do we ensure access? And after ensuring the access, are we going to monitor the use? And then how are we going to monitor the use and determine whether our antibiotics are being overused or underused? So we will look at why the dual imperative, quality and supply risks, the 5 pillars of scaling access, diagnostics, vaccines, and other synthesis. So when we talk of access, we are linking it up to access as a universal health coverage target. So the SDG target 3.8 commits countries to universal health coverage. This means that we have to think about financial risk protection and also access to safe, effective, quality and affordable essential medicines and also vaccines by the year 2030. Why are we talking about vaccines here? Yes, we have to have access to vaccines because with the use of vaccines, we will prevent a lot of vaccine preventable diseases, whereby we wouldn't end up using antimicrobials in treating our infections. Once we are protected with vaccines, it means we won't be infected and end up using
antimicrobials a lot in our facilities. So we have a core coverage indicator. This indicator talks about access to safe, effective, affordable medicines and vaccines, which is a key service coverage index component with the WHO tracks towards universal health coverage. So WHO has been tracking our performances with regards to universal health coverage and access to safe, effective and affordable medications is a key driver on this access. WHO also tracks the foundation of care. When we talk about foundation of care, we are talking about care throughout every unit of our facilities, from maternal care to antimicrobial control, which depends fundamentally on the availability of essential medicines. So with access, we are talking about a major global concern. We know that 1/3 of all world's population lack access to essential medicines. Yes, WHO is saying that the whole of the world, 1/3 of the population don't have access to essential medicines. And 50% of we low and middle income country population, we lack access to essential medicines. And our procurement system also sometimes prevents us from getting access to essential medicines. We all know our procurement lead time and how the bureaucratic processes can also lead to reduce in access to availability of essential medicines. And 15 to 25% of our medications, our essential medicines, get expired before it gets to the end user. We are struggling with access, and at the same time, the products we procure, some of them get expired before it gets to the end user. So how do we strengthen all these things to improve access at our various facilities? Availability and affordability should also be key when we are considering access of essential medicines in our various facilities. Weak supply chain systems also affect access of essential medicines in our various health facilities. Why is access an urgent item to be discussed in Ghana? We have to discuss access because when it comes to antimicrobials, the more we have access to it, the more we abuse them. And the more we don't have access to it, the more we don't also treat our infections very well. So what do? We are saying that we conducted some point prevalence survey in Ghana, and we realized that inpatients, we really use over 54% of antibiotics on our inpatients. Over 70% of these antibiotics too have grown resistance to these key bacteria that we usually find in our facility. That's the E. coli, the pneumonia species. So in this case, doesn't mean we shouldn't have enough of our antibiotics in the facilities, because we realize that when we have access, we are overusing them. And globally, we've realized that antibiotic resistant death is over 1.14 million annually. And when we look at the WHO aware classification, it's talking about facilities using 60% of our basic antibacterials we have. That's the very basic ones that are not really prone to resistance. We have to use about 70% of that antibiotics. And then the ones that can easily develop resistance, we have to be monitoring them and not use them, but reserve them for very critical infections. But looking at our data here, that 60% we've exceeded it, and we rather use over 70% of that when we have antibiotics available in our facilities. So the issue is both sufficient access and inappropriate overuse drive resistance in our Ghanaian facilities. Therefore, strengthening medicine value chain from selection through to bedside use is very essential to reversing this trend. So now we talk about the access framework. Medicines must be appropriate and they must be available and affordable to be used. We must improve access, and at the same time we must make sure that what we are stocking, they are appropriate and they are available all the time, and they must also be affordable to be used. And to ensure this, we have to make sure that we depend on policy decisions and also integrate processes across the entire value chain to be able to achieve this access framework. So we'll first of all pick on the appropriateness of the essential medicines that we have in our facilities. So this means that selection of sound evidence, selection of these essential medicines should be based on sound evidence and diagnostic guidance. We know some of our facilities may not have the diagnostics in place, but at least we should try as much as possible. And also try to match the selection of the appropriate medication with the therapeutic need of our clients. When it comes to availability, we must always make sure that the commodities are available though. So it means that we have to make sure our supply chain is very resilient in this case. So we talk about affordability. Affordability is very key to access because cost shouldn't be a barrier for accessing medications at the point of care. Now we come to the dual imperative, access and appropriate use. So we realize that when we have sufficient access, it drives antimicrobial resistance. And when we don't have enough access to it, also drives antimicrobial resistance. So we are at a dual imperative. So now, if we have insufficient access, what happens? How does it affect antimicrobial resistance? It means that we won't have enough to treat infections, and this will worsen and also spread, and this will end up in antimicrobial resistance cases. Patients will now tend to use substandard or counterfeit medications. Because the products are not available, they will get it at the facility and they will go to the chemical shops to go and get them. And over there, they might be served with products that are counterfeit or they are substandard. Also, inadequate treatment selection also causes resistance. So if maybe we are treating a particular infection and the antibiotics we have is not enough to completely treat the infection, it can result in antimicrobial resistance. Also diagnostic gaps. If we don't have the necessary diagnostic to really conduct the culture and sensitivity test before prescribing antibiotics, it can end up in that. And also when we have a lot of stocks too, how does it affect antimicrobial resistance? It affects it in that inappropriate prescribing and over-the-counter dispensing. Because the products are available, we will just be dispensing, and self-medication, because it is easily accessible. So anybody at all can walk anywhere and buy antibiotic and use, and that will cause failure to also complete prescriptions will also end up in, and also antimicrobial use in agriculture, as mentioned by our brother Mawena. So we are now looking at the 3 pillars of Objective 4 of the WHO Access Framework. So this tells us about equitable access, appropriate use, and safe disposal of our antibiotics and any other medications as well. So when we talk about equitable access, it means that antimicrobial should be available at every point in care and should be affordable and should be also available on our insurance list as well, so that any level of our clients will have access to it. When we talk about appropriate use, we have to be guided with the aware classification of the WHO, whereby we will be monitoring the antimicrobials that are susceptible to resistance and reserve some key antimicrobials to when they are critically needed. When we come to the safe disposal tool, we have to be sure that our supply chains are resilient, in that especially our staff that are in the supply chain profession, we know we have to empower them so that they don't really over request commodities to overstock, which can end up in expiries in our facilities, and then disposal becomes a challenge, which can all contribute to antimicrobial resistance. So let's talk about some drivers. What drives poor access to antimicrobials or any other medications we have in our facilities? Poor selection also drives poor access. So here's the case, decisions to treat and other evidences before we treat are not available, and that means that we will just use our arbitral decisions or assessment to select any of the medications, because probably sometimes we don't have any guidelines guiding our selection. We also talk about unreliable supply system. If our supply chain is not really resilient, that can also drive poor access of our commodities in our facilities. Inefficient procurement processes too can also drive poor access of commodities, essential medicines in our facilities. So let's look at counterfeit and substandard medications. It's believed that 10 to 20% of sampled essential medicines in Africa especially fail quality control tests. So in this case, we the DTC team, are we looking out for our medications, whether they are counterfeit or substandard? How are we going about that? It is also believed that 28% of antibiotics that are procured in especially low and middle income countries are counterfeit or substandard. So we have to open our eyes when we are procuring our medications. about expired medications, they are very costly failure to our health system. I've already mentioned that 50 to 25% of our procured medications expire before they get to the end user. And globally, especially in sub-Saharan Africa, we lose more than $12 billion annually to expiring medications. So how best can we in our facilities help to avert expiries when we are monitoring our stocks? So we are looking at 5 pillars for scaling up access of essential medicines in our facilities. So we first of all look at careful selection of our medications. Once we select our medication very carefully, we will always make sure that medications are available and we have access to them. Formulary optimization. We all know we have our formularies in our various facilities, and if we make good use of it, we will always have commodities available and we will have access to them. Forecasting, quantification, and supply planning. If we don't forecast and quantify very well the needs of our facilities, that is when we may overstock or understock, which will affect access of essential medicines in our various facilities. Pooled procurement can also help in accessing essential medicines and workforce capacity building. DTC team, are we looking at building the capacity of our supply chain professionals? Because if they don't forecast well and also don't know anything about the reorder level, the maximum stock level, the minimum stock level, they will order and procure medications, either they over-procure or under-procure, which will affect accessibility. So talking about careful selection, we've already spoken about it being guided by the use of treatment guidelines and all other diagnostics as well. So talking about the formulary optimization, we have to make sure we update our formularies too. Sometimes the formularies have been there very old. What are we doing about it as DTC team? Are we looking at updating it maybe every 6 months or yearly to be able to optimize the use of this formulary? We are also looking at forecasting, quantification, and supply planning. Are we planning on building the capacity of our professionals so that our quantification and forecasting will be very top-notch to support our commodity availability? So talking about the pool procurement too, I know we do this framework contracting. We can leverage on that to be able to procure the right medications at the right quantities and at an affordable prices as well. So talking about the workforce capacity building, let's not look at only the clinical side. Let's look at the human resource side and build our capacity all the time to be able to improve medicine availability. So beyond the medicines, what else can also support commodity availability and reduce antimicrobial resistance? We talked about the diagnosis, we spoke about the vaccines too. Once we also encourage our clients to get vaccinated, they will be protected and will contract the infections, which will end up using more of antibiotics. So let's look at some key takeaways of this presentation. So we spoke about access failure, which drives resistance. So if we don't have access to our medications or antibiotics, we won't have enough quantities to be able to treat infections to prevent antimicrobial resistance. When we talk about the 3 A's, that's the appropriate medications, the availability, and the affordability. So we talk about quality assurance as well. Let's open our eyes and look at the counterfeits, the substandards, and then look also at the expiries of our commodities before we dish them out to our clients. So when we talk about the people and the foundation, we are talking about building capacity of our professionals to be able to improve commodity access or essential medicine access. So thank you very much for your attention and any questions.
Thank you very much. Please, do we have questions for her? Or contributions? It's confusing. Okay, you did it.
I just want a clarification. You mentioned vaccines. What kind of vaccines are we looking at?
So we look at the vaccines that especially protect us from these infectious diseases. So when we look at the TB vaccine, that the BCG is protecting the babies from contracting tuberculosis. And you know, when we contract tuberculosis, we end up using a lot of antibiotics to treat. So once we vaccinate against the tuberculosis, the babies wouldn't be contracting the TB for us to go ahead to use antibiotics. And even diarrhea, we have to vaccinate. We use the rotavirus vaccine to vaccinate against diarrhea so that we don't end up using antibiotics to treat diarrhea in the babies.
Very well delivered. Thank you very much. Yes, so we are about rounding up. Now we will call on Rich to tell us what plan they have.
Thank you very much, Ghana Health Service, for this training. As a facility, we don't have an action plan skewed towards EMS as at now. But just like Mr. Broker started from yesterday, we have started something. And we have also started recruiting members to form the EMS committee, subcommittee, and DTC. Together with all that we have learned from yesterday and today, we want to promise you that we will sit as a committee and come up with an action plan on EMS, and we wish to do that in 4 weeks. Yes. So we will let you have the feedback when we are done. Thank you very much.
Thank you. We will hold you to your word. You know, rain is the eye of the region, so this whole activity is taking place because over the years there's been a lot of activities going on around AMS or AMR. AMR has been around for quite some time. Individuals are doing their own thing to see how best to curb it. Facilities are also doing their own thing. But as a service now, we really want to coordinate what we are doing. Partners are also helping different facilities at different points doing a lot of things, but we want to have a coordinated approach so that we can learn from one another, and then together we all move forward. So going forward, it's not only RAGE. This training is going to take place in various facilities. For Greater Accra, we started with RAGE. We'll be moving to Tema General, but as you all know, RAGE is the eye of the region. So we will be looking, there's more interest here. If RAGE takes the lead, then we know that we are doing well. Others can come and learn from you. As a regional hospital, we don't want to go and learn from the smaller facilities. We should set the pace. So we are there to support you in whichever capacity. We know that this PPS that was being talked about, we need training in it. We can't just expect you to carry it out. It will need training. So we are there to support you. One thing I'm very, very impressed about in these two training is the presence of the medical director. I'm highly pleasantly surprised that he has sat with us from the very beginning, the very first day. He was here before most of the members came. And I know he's a busy man. He sometimes have to let the people come to him here, but he didn't leave us at all. That tells you how leadership is very committed. So we know that this one is going to succeed. RAGE is not going to fail in any way. So director and team, we are very grateful for you having us, and we want to assure you that we are there to support you to run this, and you all coordinate and learn from each other. Thank you very, very much. I will call ISP to give us their final remarks.
All right, so on behalf of the Integrated Health Partnership Project, that's also known as Project Hope, we want to say thank you very much for your attention and participation in this training. So going forward, we know that our DTC is now going to be very strengthened, and this will improve access of essential medicines and also reduce antimicrobial resistance in our facilities. So, ladies and gentlemen, thank you once again, and probably we will come your way again, and we know that you open your doors to us once again. Thank you.
Director has hosted us very well, so I was bringing it to you.
Thank you very much. So I'm happy that 2 days has come very fast. And one of the reasons why I was here is because I usually take opportunity to hide from the office. There's too much work there. So when I have opportunity to come and join an important program, I take it and then I come and stay here. So it's good. And like I said earlier, I wanted the team to be dominated by the heads of department, because I noticed that usually leadership plays a very important role in driving some of the activities of various units, and this particular one influences our practice a lot, and it will tell on the quality of the service that we provide. And as we all know, general health service is high on quality. Usually, you want to be sure that the drugs you have in your hospital are high quality. And in fact, the other one is that they are available. You are not happy when you meet people walking out of the hospital with prescriptions to buy drugs that you assume were available. You know, things like that. So that's why I think that all the leaders should be part of the DTC to ensure that the various bottlenecks are addressed properly. If it's procurement, it has to do with finance, from clinical, from the doctors, we should all be part of the solution so that the hospital is positioned well. This training, in fact, last year my objectives for appraisal for regional director, most of them were on drug, the medicines, the percentage of antibiotics, percentage of generics, you know, a lot. There was a whole list of objectives only on drug. Unfortunately, at the end of the year, there I scored 100%. Wow. Yes, I scored 100%. So I'm hoping that the team will support us to maintain the performance of last year and make sure that more drugs are available in the hospital. We want to reduce the number of times that people have to walk out of the facility because we don't have the drugs readily available. When it happens that way, then the cost on the patient becomes more because when they go out, what they are paying for sometimes is like 2 times what we would have charged in the facility. So it affects their overall satisfaction of the care they receive. So you finish attending to them. Okay. So at the end of the day, when they are out of the facility, their overall satisfaction sometimes it's not very good. And it's not because they didn't receive the best of care, but because they have to walk around a lot. They have to look for drugs that they thought were available, and they went to the pharmacy. They had to wait for a long time because we didn't have enough staff. We don't have enough staff, and we run multiple pharmacies 24 hours. So sometimes it's a staffing problem, and people are overwhelmed. And in Greater Accra, when you give the patient the option that I need to refer you. You want to go to 37 range or volume, they will all mention range. So every time our emergency is full, every time our wards are full, every time you have patients at the pharmacy waiting for medicine. If I hardly have I gone to the pharmacy and see that there's nobody there waiting for medicine. Every time. So it means when you come to work at the pharmacy, you get your feet to close. So it puts pressure on us. So staff is major on our list. It cuts across. In how our patients interpret quality of care. They've come to hospital. They want to take medicine home. So medicine forms an integral part of the work that we do in the hospital on a daily basis. So this committee, I'm happy that Dr. Mrs. has done a very good job, made me score 100% at my performance review, and she's still part of the DTC. So we are just going to let the whole hospital know that medical director is part of DTC. That's it. So the work that the members have been doing will continue to do, and will provide more hands to do the work. I mean, yesterday and today, it's obvious that we need to increase the membership. There are some key people that we need to get to be part of the team, and we will do that. And then will be it is the quality of work that we want to improve. So thank you very much for coming. And we promise to do well. Dr. Mrs. says I should announce that the very nice food we have been eating has been provided by the training team from Ghana Health Center. Thank you very much. It's like balanced diet. It's like I'm eating something different. I'm eating snacks every time. This one is different. So thank you very much. All right.
Thank you, Director. We've now closed the place. We are rounding up. We have some evaluation forms, please. We want you to fill for us and score us whether we score 0 or 50.
What's your mind? Okay.
a Friday. We don't want to waste time in between, so we will let Chief Pharmacist to say something. From the written, we've been supporting these 2 days by the Chief Pharmacist.
Thank you very much. Has been very interesting, isn't it? Yeah. And it's a refresher, so we've been refreshed and we've also been strengthened. So we are expecting DTC to do more going forward, isn't it? Then we are also expecting maybe a subcommittee of the DTC for antimicrobial stewardship, and we will come up with their recommendation. Indeed, I want to commend management, medical director and his team. They've supported us by their presence and they show that they are committed to ensure that DTC really succeeds. And indeed, DTC is the highest governing structure in the facility concerning medicine and medication therapy. And it's a problem-solving committee. So all challenges, the bureaucracies and the difficulties relating to making medicine available, accessible, ensure that they are rationally used, and even after use, whether the patients are recovering or they are satisfied or they are not satisfied, all the challenges, when it comes to you, you are supposed to sit on it and resolve all these challenges so that we move forward, meeting the needs of the patients. We expect quarterly reports, at least from the DTCs. Every quarter you will be meeting. And when you meet, over the past 3 months, what happened? You review your activities. Were the medicines available? Were the bulletins available? When you use the medicine at the wards, what happened? At the OPD, what happened? Are there any challenges you need to resolve? So you put your heads together. Then all these experts that we put together as a committee of a different angle, all of you will bring what you experience, your experiences with the medicines. So the example of shared, you can resolve those challenges here. You come up with policies to address these challenges. And you have management commitments. So once you have these policies, everyone practicing will just follow it because you have really disseminated and posted it at the relevant points. Then all will follow so that we will achieve the common good. And the last presentation really touched my heart, which is about DTC making sure that the medicines, they are available, they are accessible, and they are affordable. DTC's core mandate. So if the medicines are not available, what are we doing? What will we wait for? What are the challenges? What can be done to improve upon it? As you meet every quarter, you look at the 3 months, what happened? Then you plan for the next 3 months. So what is going to be done? This point prevalence study, if you are going to carry it out, it's not easy. You need to really plan, get people involved to get it done. In fact, the work is broad, but you can't do it all at the same time. So you commit people to certain things, they come back to the committee, they submit their report, then we discuss and find a way going forward. So on that note, we expect a strengthened DTC, we expect strengthened performance, better patient outcomes. That's what we need. In fact, I always say that Rick is the touch blazer. They light the touch, they lead the way, and the others follow. So we expect more from you. On that note, thank you very much for having us, and thank you for your participation.
Hey, again.
It looks like we have closed a little bit earlier, so lunch is not here. That is what is keeping us a little bit. I don't know if we will go and let it be sent to us, or we will just hold on a little bit more. And director is permitted to.
Thank you very much.
So before director leaves, I want to thank you all for making time to be part of this training. This wouldn't have happened without you being here. Those that were able to make it for the 2 days, we are most grateful. For all our facilitators, thank you very, very much for coming to impart this knowledge and sharing your experiences. thank you to our chief pharmacist who has also been here, Dr. Felix Opariado. Thank you so much. Thank you, Director of Pharmacy Asridge. We are grateful. All the heads of departments that were here, we are most grateful. Dr. Buama, thank you so much for making time today to be with us. Thank you all, Pharmacy Department and everyone that was able to make it. Thank you. That would please, shall we be outstanding as we have the closing prayer?
Shall we pray? Heavenly Father, we thank you. We give you all the glory. We give you all the praise. We thank you for being with us as we prayed for. We thank you for a very successful training workshop. We ask that whatever we've learned here, you will grant us the wisdom to be able to implement them for the service and for the good people of Ghana. We pray in Jesus' name. Amen.